Right, sir. Everything is set. Thank you, sir.
అన్నం తినిపిస్తున్నానా
कि तुम
हाँ सही बात
सर
सर छोटा चलाए
एक तो सड़क की
बात
बंद है। चलने दे, ये चलने देना। ये क्या होगा, स्टिल कैसे होगी? हाँ, यस। हेलो हेमा बिंदु मैडम, गुड इवनिंग।
गुड इवनिंग देवेंद्र सर। गुड
हाँ
इवनिंग
नमस्कार
सर।
मैडम, नमस्कार।
नमस्कार सर। नमस्कार सर।
कैसे हैं श्रीदेवी मैडम? गुड इवनिंग।
हाँ
सर गुड
गुड इवनिंग
इवनिंग।
सर। गुड इवनिंग सर। गुड इवनिंग।
गुड इवनिंग। ओहो, रिकॉर्डिंग बहुत जल्दी स्टार्ट हो गई।
हाँ जी, अभी तो मैडम जो आप लोगों के प्रोग्राम होते हैं ना, वो
हाँ
बिल्कुल
सर
पहले ही
सर
हो जाते हैं। बिफोर
सर
टाइम हो रहा है तो और भी बढ़िया बात है, रिकॉर्डिंग और भी पहले शुरू हो गई है ना
सर
मैडम।
सर ये बिफोर टाइम हम लोग इसलिए करना चाहते हैं कि 10-15 मिनट में पहले है ना एक दूसरे को फॉर्मल वेलकम इनकमिंग और
मैडम
विशेष
वो
कर
बहुत
लें।
अच्छा, इसमें
हाँ
मैडम बहुत चार्मफुल रहता है ये चीज ना, हर एक से बातचीत हो जाती है,
सर सर
ऐसे
सर
लगते हैं
सर।
आमने सामने बैठे हुए हैं जैसे, है
अरे
ना।
बिल्कुल सर, ये तो इसका एडवांटेज मिला सर हम लोगों को। कोरोना ने बहुत कुछ सिखाया और ये
बहुत
वाली चीज
सिखा
तो
दिया।
बहुत, ये
कम
तो
से कम
बहुत।
ये चीज तो अच्छी होगी कोविड के बाद।
नमस्कार आनंद
आनंद
शर्मा सर।
शर्मा सर, गुड
नमस्कार
इवनिंग
सर।
सर।
नमस्कार।
डॉक्टर सरीन
हम्म।
सर।
सर
यस सर, नमस्कार सर जी।
नमस्कार सर। नमस्कार सर। नहीं तो पैन इंडिया मिलना बहुत ही मुश्किल होता था, कॉन्फ्रेंसेस में ही मिल पाते थे।
बिल्कुल सही है मैडम।
हम्म।
और कॉन्फ्रेंस में भी मैडम एक्चुअली क्या है, डिनर के टाइम में मिलना हो जाता है सबसे ना, बाकी
बस
तो
बस।
सेशन में कोई इधर या लंच या
हाँ,
डिनर
सही बात है,
के
लंच या
टाइम में।
डिनर में सर। नमस्ते मैडम। गुड
नमस्कार मैडम,
इवनिंग।
वेरी गुड इवनिंग मैम।
नमस्ते सर, हाउ आर
नमस्ते
यू?
मैडम। नमस्कार मैडम।
हाँ
नमस्कार।
नमस्कार
नमस्कार।
गुड
श्रीदेवी
इवनिंग
मैम।
मैडम, गुड इवनिंग।
देवेंद्र सर, सरीन सर,
यस
नमस्कार।
मैडम, गुड इवनिंग,
या
नमस्कार
अभी तो
मैडम।
मिले थे इसी वीक में। शर्मा सर कैसे हैं आप?
ठीक है मैडम, बहुत बढ़िया।
जी सर, एमकेसी नायर सर और ये फोन किए कि हमेशा हम करते हैं, आप किए क्या?
नहीं, उनको हमने मैसेज किया है मैडम, फोन करना भूल गया।
मैसेज नहीं देखते हैं वो।
बहुत
मैसेज नहीं
ज्यादा
देखते
उनको नहीं,
भैया,
उनको
मेल भी।
बताया है।
मेल
एवरी
देखते हैं,
टाइम आई
मेल
कॉल
देखते
एक्चुअली,
हाँ जी हाँ
बट
जी।
आई थॉट कि लेट आर्या सर डू इट दिस
नहीं,
टाइम।
मैंने है ना मोस्ट ऑफ द चेयरपर्सन को मैसेज किया मैडम।
मैसेज नहीं सर, दे रिक्वेस्ट
मेल
हाँ
कर दिया करो
सीनियर है
पर्सनली,
मैडम।
दे
वो भेज देते
डिजर्व
हैं
अ
सब।
फोन
पर्सनल
करना चाहिए,
कम्युनिकेशन।
फोन करना चाहिए।
इतने सारे
आर्य सर
वेबिनार
गुड
हो गए ना।
इवनिंग।
हम्म।
आर्य सर गुड इवनिंग।
हाँ गुड इवनिंग सर।
డాక్టర్
गुड इवनिंग।
శ్రీదేవి బాగున్నారా?
యా బాగున్నాను మేడం.
వెల్కమ్.
యా ఐఎమ్ గుడ్ మ్యామ్. హాయ్ మ్యామ్. హాయ్
యా
సార్.
హాయ్.
हेलो गुड इवनिंग
They
मैडम,
are
गुड
all
इवनिंग,
central
गुड
age
इवनिंग।
people.
यस
Maybe,
यस मैम.
like take over central zone adults con, and
हाँ.
you, uh,
हेलो।
we have to discuss that later.
तो कल कल
नाउ
सुबह
मैम.
कल बाहर हो? कितने बजे निकलोगे? कितने बजे? अब कितनी देर में, या अभी कितने बजे फ्री हो गए आप? अच्छा, तो अब आओगे, अभी आओगे या फिर, या फिर परसों परसों आओगे? कितने शाम को? परसों शाम को या अगले दिन आओगे? अच्छा अच्छा। हाँ, चलो फिर, चलो अपन बात कर लेते हैं परसों, फिर देख लेते हैं जैसा आता है ना। ओके ओके। कल आ जाओ, उनके दिन में आ जाओ तो बेस्ट है। तो कितने बजे, कितने बजे बताओ मुझे। तो मुझे 2 घंटे पहले, 1 घंटा पहले बता देना, बस मैं घर ही मिलूंगा वैसे। लगभग कितने बजे, 1-2 बजे, 1 बजे, 12-1 बजे, 2 बजे ना। सुबह सुबह आ जाओ, 8 बजे बाद मैं घर ही हूँ बस, है ना। 8 बजे बाद आप फोन कर देना कि मैं आ रहा हूँ बस में, है ना। ओके, वो बढ़िया रहेगा, सुबह 8 बजे ना। ठीक है। गुड इवनिंग सर, परम सर, गुड इवनिंग। शामिल घोष सर, गुड इवनिंग।
गुड इवनिंग।
गुड इवनिंग।
Very good evening. I'll just returning home on the road, Dr. Sareen.
यस सर, गुड इवनिंग
Very good
सर।
evening. Namaskar, sir.
आई नो। हाँ, आप यू आर इन द ट्रेवलिंग ना, बिल्कुल बिल्कुल
हाँ
सर।
हाँ, आज यहाँ बहुत बारिश हुई है, so the roads
अच्छा
are all jammed.
अच्छा अच्छा।
अचानक से अनसीजनल शावर्स, लोग बहुत खुश भी हैं।
सर यही होता है सर, अनसीजनल में यही होता है, जब होती है बारिश तो पता लगता है कहाँ कहाँ पे गैप्स हैं, कहाँ खड्डे हैं, तो सब एंड यू हैव टू बी वेरी केयरफुल इन ड्राइविंग सर। बिल्कुल
Yeah.
बिल्कुल सर।
तो बहुत
चलो
खुश भी हैं लोग, काफी गर्मी चल रही थी, बट
हाँ
रास्ते
जी,
भी जैम हो गए।
यस सर, यस सर।
ठीक
तो
है,
ग्वालियर में हम लोग एंजॉय कर रहे हैं 45 डिग्री।
एक्सलेंट।
45 डिग्री सर।
अंडे तो छत पे ही बन जा रहे होंगे ना, गैस
बिल्कुल
चूल्हा
सर,
सब बच गया।
गुड इवनिंग प्रियाली मैडम, गुड इवनिंग।
काली मैडम गुड इवनिंग। नमस्ते नमस्ते मैडम, वेलकम मैडम।
सरीन सर नमस्ते।
मैडम गुड इवनिंग। प्रियाली मैडम वेरी गुड
सभी।
इवनिंग।
Good evening, Piali ma'am. I'm
अरे वाह,
Sridevi.
श्रीदेवी इज हेयर। Of
Ma'am.
course I know you, Sridevi. You
Yeah,
don't have to introduce.
yeah, yes. Thank you,
Active worker of AHA.
ma'am. Thank you, ma'am.
चलो, Hima is also here. Think अपने आर्या जी is here. He is going to be the MOC
हाँ
today.
जी मैडम।
Great, great. शर्मा सर भी आ गए हैं।
हाँ शर्मा सर आ गए, लेकिन वो
वेरी
निकलने
गुड
के लिए
गौरी,
तैयार
गुड इवनिंग
बैठे
मैम,
हैं।
वेरी गुड इवनिंग।
आपकी सुंदर वाली शक्ल तो दिखा दीजिए सबको। ये देखो आ गए। डॉक्टर शर्मा, एक हमारे जौनपुर वाली बंदी है, वो कह रही है इसको मेंबर बनना है,
हो जाएंगे।
तो फॉर्म वॉर्म कहाँ पे है? आपको सुनाई नहीं दे रहा, म्यूट पे हो।
ऑनलाइन हो रहा है तो लिंक आपके पास होगा, नहीं तो हम भेज देंगे।
आप भेज दो, मैं उसको भेज दूं।
मैम बिल्कुल भेज देंगे।
अभी गए थे ना जौनपुर, तो बहुत अच्छा प्रोग्राम हुआ वहां पे। उन लोगों ने तो IMA फॉक्सी सबको बुला लिया।
मैडम यही करना चाहिए, यही करना चाहिए
बहुत
मैडम।
बढ़िया प्रोग्राम
सभी
हुआ। हमें
सभी डॉक्टर
बच्चों
हैं और
को भी
सभी
बुला
चीजें
लिया।
related होती है उनकी।
सुकांता सर ने
हेलो
भी
हिमा।
ज्वाइन कर लिया। सुकांता
गुड
सर गुड
इवनिंग डॉक्टर
इवनिंग।
प्रियाली।
गुड इवनिंग, गुड इवनिंग।
सर गुड इवनिंग।
इवनिंग
गुड
हिमा।
इवनिंग,
हाय,
शुभंतदा
हाउ आर यू?
नमस्कार।
गुड
सुकांता
इवनिंग
सर गुड
हिमाबिंदु
इवनिंग।
मैडम, गुड इवनिंग
गुड इवनिंग
प्याली
सर।
मैडम,
शक्ति
गुड
मैडम गुड
इवनिंग,
इवनिंग।
गुड इवनिंग सर।
गुड इवनिंग
शांता सर गुड
शर्मा
इवनिंग
सर, गुड
सर।
इवनिंग।
गुड इवनिंग सर।
डॉक्टर
यस, गुड
सर
इवनिंग।
प्रगति को कौन किया आप?
ये कौन है? रश्मि है। और कौन कौन है? मेरे को टेंशन क्यों दे रहे हो भाई? मेरे पैनलिस्ट ज्वाइन कर लो।
टेंशन मत करो।
सर पैनलिस्ट नहीं है, मैं मॉडरेटर अकेले हूँ।
मैडम हो जाएंगे मैडम, तब तक जब तक ये लेक्चर हो जाएगा उनका।
नहीं सर, 15 मिनट ही है, दे शुड ज्वाइन।
हाँ मतलब ये तो हमने बोला, सबको मैसेज भी किया था कि सब लोग है ना कम से कम 5 मिनट पहले ज्वाइन करें।
श्रीदेवी और मैं दोनों मॉडरेटर बैठे हैं।
हाँ गुड
हाँ
इवनिंग मैडम।
चंद्रमोहन
मैडम
जी,
संगीता
चंद्रमोहन
मैडम,
जी, गुड
लॉन्ग
संगीता
टाइम
इवनिंग।
मैडम
नो
वेरी गुड
सी।
इवनिंग।
सर प्रकाशवीर सर, आपने कहा 5 मिनट पहले, तो हम बिल्कुल आ गए।
हाँ नहीं, थैंक यू सर, थैंक यू सर।
नमस्कार सर।
अरे
सर
ये
आप ही
अपना
का प्लेटफॉर्म है,
चंद्रमोहन
आप ही की
है।
मीटिंग है सर।
आज प्याली मैम को बहुत दिन बाद दिखा।
नहीं ऐसा मत बोलो, प्याली मैडम तो।
हमने भी इसको बहुत दिन
संग-
बाद देखा।
संगीता मैडम, गुड इवनिंग।
हाँ
वही कह रहे मैम। सर नमस्कार
चंद्रमोहन,
सर।
गुड इवनिंग। चंद्रमोहन, गुड
नमस्कार
इवनिंग।
सर। सर नमस्कार।
Good evening, Hema.
संगीता मैम नमस्कार।
माँ फोन पे
गुड
लगी हुई है
इवनिंग
मैम।
मैडम, गुड इवनिंग।
Now I.
गुड इवनिंग, गुड
Hello,
इवनिंग।
Dr. Prakash.
चंद्रमोहन
हाँ,
तुम्हारे
चंद्रमोहन जी
नमस्ते
गुड
मैडम,
इवनिंग।
Good
नमस्ते
evening, Dr.
मैडम।
डॉक्टर
Kavinder.
चंद्रमोहन
Padri
सर गुड
madam has
इवनिंग।
also joined.
सर गुड
So
इवनिंग सर, गुड
excited, no?
इवनिंग।
Like adolescents.
Yes.
Sir, it is 9:02. Shall we start the meeting?
902-857 है तुम्हारी
अच्छा,
घड़ी थोड़ी सी आगे
madam,
Yes,
3
ma'am.
minutes है
Wait,
madam.
8:57 IST.
Okay, okay, okay.
So
Hello,
Hyderabad
Piali,
standard
how are
time
you
में
doing?
5 मिनट.
Good evening, Geeta Patil madam.
गुड इवनिंग गीता
ऐसे
पाटिल
ही
मैडम, गुड
तमाम ठीक
इवनिंग।
है सब, ऑल गुड।
Good.
गीता मैम नमस्कार.
It will be nice to meet in face to face, no, and अच्छा लगा.
Good evening, Sangeeta madam.
Good
Nice.
evening, Dr. Geeta.
इवनिंग
Sikanta
संगीता
sir,
मैम।
Piali, all Sharma sir, Arya sir, Madam Himabindu,
Good evening, Geeta
all
ji.
Lakshmi is there.
डॉक्टर शर्मा को देख के
2
ना
more minutes, sir.
आगरा की कॉन्फ्रेंस से याद आ जाती है. डॉक्टर सुकांत और
सही है।
शर्मा को देख के कोलकाता वाली याद आ जाती है. डॉक्टर गीता पाटिल को देखकर वो वाली बैंगलोर
बैंगलोर वाली।
हम लोग ने चंद्रमोहन कुछ करें एम्स पटना में.
चंद्रमोहन कुछ करेंगे अभी मैडम, हमको बिहार बुलाएंगे अभी पटना।
एम्स
Good evening,
पटना में
Pragati madam.
इस
Good
बार
evening.
अपना हमारा करते हैं मैम एक
Pragati
midterm
madam,
करते हैं.
good evening. Welcome to the IAPHA forum.
आप बिड करो,
Thank you,
पटना ले
Dr.
जाओ, फिर
Pragati.
हम चलते हैं।
Good evening, Pragati madam.
Yes, ma'am.
Pragati,
Yeah,
special
good evening,
welcome
Dr.
on
Piali.
behalf of IAPHA.
अच्छा, प्रगति से
गुड इवनिंग प्रगति मैडम, गुड इवनिंग।
Good evening all. Namaste ji.
नमस्ते.
नमस्ते मैडम.
आर्या सर, सबके सीवीज है ना आपके पास?
अभी तो मिले थे ना लास्ट.
हाँ जी, हाँ जी.
और कोलकाता.
I hope the EB members have joined, sir.
डॉक्टर प्याली, that
Yes, sir.
Rajamundi
सबको
used to
invite
do
किया
that,
मैडम,
remember
सबको
that
टाइम से
temple
बोला.
we visited.
हाँ जी मैम। हाँ,
अच्छा.
धर्मेश सर, गुड
मैंने
इवनिंग।
अपने
Sharma ji is, I think, out
लोगो
of
लगा
country.
रखे.
डॉक्टर शमिक प्रकट
And
हो
of my
जाइए.
emails.
Very good evening to everyone.
इतने लोग
Yes,
बातें
yes.
कर रहे हैं ना
गुड
मैम,
Very,
इवनिंग
very
भाई,
good.
गुड
समझ में नहीं आ रहा है।
इवनिंग।
I know.
Good evening, Shamik. Good
Vivek,
evening.
please
Very
mute
good.
ना.
कहाँ है शमिक? तो नहीं है, कौन
वो
बोला
प्रकट होने के लिए कहा मैंने
हाँ,
उनको.
काल
अवश्य
বৈশাখ
प्रकट हो.
है कहाँ?
দিদি একটু কাল বৈশাখী হয়েছে, একটু দেখতে পাচ্ছেন না।
ओ अच्छा।
नहीं, काल बैसाखी नहीं, सादा बैसाखी है।
अभी बंगाली से महाराष्ट्र.
Focus light on your face.
हरमेश जी, गुड इवनिंग। गुड इवनिंग हरमेश जी।
हरमेश
Good
सर, गुड
evening.
इवनिंग.
हाँ, जलील
जलील
साहब,
भाई,
गुड इवनिंग।
गुड इवनिंग.
Good evening, Dr. Jalil. Good evening, Dr. Harmesh.
गुड इवनिंग हरमेश सर, गुड
इवनिंग जलील
इवनिंग।
भाई।
और
भाई,
बैसाखी हो
गुड
गई.
इवनिंग।
And
डॉक्टर
Dr.
जलील,
Yeah, I think everybody is muted because we want to start the meeting. Yeah. So, Dr. Arya sir, please unmute yourself and you can start the meeting. Vivek, you can start the recording. I
Yeah,
hope.
yeah, madam, the recording.
Madam, I am recording.
Yeah.
Yeah.
Very good evening. I welcome all the esteemed dignitaries from CIAP, Central AHA, and from the EBs of various zones. Okay? Esteemed senior members and respected speakers and moderators of various programs and panelists. Least but not least are youth ambassadors present in today's webinar. Now I welcome our chairperson, Dr. Himabindu Madam, for the formal welcome of the speakers.
Thank you. Thank you, Arya sir. A very good evening and respects to all the seniors and greetings to all my colleagues in IAP and AHA. This is another super specialty webinar of our AHA. We all are celebrating, we all are aware that we are celebrating the Silver Jubilee year and we want to do something special so that we remember as a milestone, and we have taken up super specialty topics for the webinars. So this, our scientific chair, Dr. Sudhir Mishra, has selected the adolescent gynecology topic for this month, and thank all the panelists and speakers who have consented to be part of it. And especially, I would like to thank and welcome Dr. Pragati Kalatkar, who is a senior pediatric gynecologist, and I should say half IAPN. And we are already working with her in girl-child module and other aspects also. So I'm very much familiar with her, and she's so well organized And she's also part of our common forum, this sexuality, comprehensive sexuality education with Sukanta sir, Geeta madam and all. So Pragati ji, we have long way to go. We have to work together. And pediatric, adolescent health also, there's an overlap between not just neonatology, even adolescent health. We can all work together, gynecologists and pediatricians. So there's so much in our action plan this year, and we would love to work with you. A long association is important between the pediatricians and gynecologists. So we have this very shortly. I want to say for the information of all the colleagues here. So we are almost at the end of the boy module is almost ready for we'll be having shortly the workshops regarding this adolescent boy module. The parenting module is also ready. We want to update it, and this also will go into in the form of workshops and the frequently answered questions. Because as a consensus, the parenting committee of IAP-AHA has uploaded it on a AHA website, and we are also going to make an effort to start Yuva clinics in some of the medical colleges with the under the guidance of Dr. Harmesh Bensji. So all the EB members have been given some responsibility, and we also would like to welcome our young people here. Dr. Ashim Ghosh, convener of Boys Module, is here. Thank you, Ashim. Dr. Ashmi,
Thank you, madam.
parenting section, she is taking care. And then we have Naumika Khanna, special welcome. She's a UNICEF ambassador, a youth forum. She's an icon, and she's been specially introduced by UNICEF to us. Naumika, you're very, very sweet, and you are so forthcoming. She's been connecting us with a lot of youth across India. And the Wave 18 is something very, very unique this year. First time we have created an Adolescent Health Academy Youth Forum. So in this youth forum, we have 350 plus youth already joined. And this every month, the 18th, we are doing a awareness program involving youth. So it is all about youth. The youth-led panels are there. They are moderating the sessions, and we have some songs being released, a quiz is being conducted. So please do join all of you on this tomorrow again, which is on April 18, and we are focusing on preconception care and adolescent vaccination tomorrow. And Geeta Bansal, madam, thank you for recording all our activities, and all hard work is being done with all of us as a team. And Sukanta sir, Geeta madam, thank you.
Thank you, ma'am. Thank you.
Yeah, thank you. All the best for today's webinar.
Now I invite Dr. Sangeeta madam, the chairperson of the today's madam, इससे पहले और विशेष के लिए बुला लें क्या?
Yeah, please. Dr. Geeta Patil.
Geeta Patil madam for the.
Good evening, Prakash Veer Arya sir. Thank you very much for giving me opportunity. I know that today's session is very important for pediatricians, and Pragati madam is there. Still, in spite of that, I like to tell that menstrual problems in young girls, they are more comfortable with the pediatricians. But same time, we don't forget our colleagues, gynecologists, to take their opinion also where it is required. Most of the time, we can solve the problem, and we need to know about the things. As Naumika is there, I'm very sure she will tell that pediatricians, they are more friendly to tell their problems because they are coming to us regularly, and many problems we are going to discuss now. And all eminent moderator is Dr. Piali madam, and all eminent panelists are there. Pragati madam is there, Usha Banga madam is there, and all of them are going to enlighten us about this program. I think Dr.
We have Chaitra also, Geeta. Chaitra, can you please put your video on? A youth, another youth.
Lakshmi Shanti, Naumika, and then
Chaitra.
So thank you very much. I think we should move on to the scientific program. Thank you again for giving me opportunity.
Dr. Sukanta sir, aapki blessings. Dr. Sukanta sir.
Well, good evening to all the dignitaries here. My chairperson, Dr. Himabindu Singh, immediate past chairperson, Geeta Patil, and other dignitaries and colleagues here, and special guest, of course, Pragati Khalatkar madam, with whom we are working. I must say that adolescent health is not the AHA job, neither IAP's job. It is a primary health care. So we need the service of all specialists, the adolescents, not only gynecologists, psychologists, and psychiatrists, and all that. So this is a holistic approach we must make, and it's a good attempt. I must say that we are incorporating speakers like gynecologists that will enrich ourselves, and also will be able to serve adolescents in a better way in the absence of gynecologist. And there will be less referral and timely referral if necessary. Thank you. With that, I hand over the mic to our Secretary Pokashji to take it forward.
Thank you, sir. Now I started our formal webinar. I introduce Dr. Sangeeta Yadav, the chairperson of today's webinar. She is Professor Sangeeta Yadav, presently working as professor in HMI, SR and HSC, was Professor of Excellence and ex-HOD of Pediatrics, MEMC, a premier institute of University of Delhi 34 years ago. Have more than 40 years of teaching experience. She completed her graduate and post-graduation residency from Premier Institute of Lady Hardinge Medical College and Kalavati Sharan Children's Hospital. She is an active member of IAP, got FIAP in 2008, received many research awards and published more than 170 papers and articles in books of journal. Holds a large number of posts, Vice President 2021, Joint Secretary Liaison 2018, and founder member of AHA 2000 and chairperson AHA 2016. Welcome, Dr. Sangeeta, madam.
Thank you, madam, for accepting to be with us today.
Very good evening. Thank you, Himabindu, and for having invited me and given me this opportunity to I would like to congratulate for this super speciality webinars which you have thought of, and along with Prakash and your whole team, and your supported by your executive board members as well as your secretary and treasurer and your past chairpersons who have been actively supporting you for this, taking this program forward. And I'm very happy you have had wonderful webinar topics, and which are of immense benefit for the adolescents and a learning experience for each one of us. And today we have adolescent gynecology as the theme, and who else would be best person to address this issue is Dr. Pragati Khalatkar is with us today. She's going to talk about a very important topic, that is how to reduce teen pregnancy. And teen pregnancy is an issue, and we have been talking about it ever since IAP Adolescent chapter came up in 2000, when that emergency contraceptive came up, and all our friends from the AIMS gynecology department and other major hospitals were talking about it and how to address. And another very important thing which has come up, and we have an illustrious panel for the panel discussion, and we also have the youth voice who are going to give their opinions and what is the need and how one should, because they are very savvy. They will be able to enlighten us how we have to address the issues which concern them. So that is the best part of this webinar. Yes. And so without much ado, I will just introduce Dr. Pragati. And we all know Dr. Pragati. She is the director and consultant at Khalatkar Hospital for Mother and Child. And she is one of the best gynecologists and obstetrician and sonologist in Nagpur, Maharashtra. She's also been president of Menopause Society of Nagpur, and with more than 19 years of clinical experience. And she's very popular, and she's very cooperative, and she's very supportive, and she listens to everybody, and she addresses their issues, and that is the best. Actually, this is what the youth needs. They need somebody who will listen to them and who will understand them and try to address their issues the way they perceive it. So that is the most important part which Dr. Pragati is going to address, and definitely the pregnancy teen reduction is an important thing. So over to Dr. Pragati, and thank you very much. And I'm sure we are all going to have a wonderful academic session and learn how to move forward in our clinical practices. And all our stalwarts are there. Once again, hello to each one of you with whom I have worked sometimes or the other in different forums. Thank you very much. So over to you, Pragati.
Yes. A very good evening to all. Thank you, Dr. Sangeeta Yadav, for a wonderful introduction. Can I share my screen first?
Yes, yes.
Yeah, so let me share.
Dr. Naumika and Chaitra, you can actually ask questions to all our experts here. So I hope you'll be here with us throughout this 1 hour. And you can actually ask questions after the session, in between, before the panel, after the panel through. You are welcome.
नहीं तो ये ऐसा होगा नहीं full share, full screen share. Something like this. Yeah, ठीक ऐसे आएगा. Is it visible to all?
Slideshow.
Yes,
Slideshow.
slideshow is on.
Yeah, now it's okay.
So at the onset, first of all, I pay my regards to all the superstars of IIP. Though I can't see few of the faces, Dr. Vasant Kharatkar, Dr. Neelam Mohan, Dr. Basavraj, Dr. Atanu Bhadra, and Dr. Yogesh Parekh. And I can see the AHA team. And I wish you all for the Silver Jubilee year. Your association has become adult. From adolescent, you have brought it to the adulthood already. Your association, AHA, has come to adulthood, and you are really solving problem of all the adolescent kids. So really my regards to Dr. Sushma Desai, Dr. Geeta Patil, Dr. P.V. Arya, Dr. Sneha Godkar, and Dr. Shamik Ghosh. I can see many familiar faces, and these voices I hear daily on phone when the meetings are going on, and daily these names are coming and falling on my ears, and daily I see all of you. So a very good evening to all. And here today my topic is very sensitive issue, that is teenage pregnancy and working for reducing teenage pregnancy in global, joining hands for the global call. A very important issue and a very sensitive issue, which is connecting obstetricians and pediatricians, a very gray area where both of us work. So before I reach on my topic, what I feel is pregnancy is the biggest abuse of childhood, if any. Any child who becomes pregnant when the body is not mature and the mind is not mature, and unfortunately she can fall victim, and when she is not willing to be pregnant and she is pregnant, is really a curse to the nature, I can say. So first of all, as you all know about is adolescent, but from sexuality point of view, it is typically a period of transition between childhood to adulthood with the major psychological tasks, which determine identity and develop a power to make decisions and develop a mature sexuality. So during this as adolescent phase, sexuality start maturing, and then there are chances that where the child can become can conceive. So before beginning my talk, actually, I really want to quote few examples. Long back, many times it has happened that some patients come to our hospital and they are admitted with Vasant because the patient was brought by the parents for gastritis or vomiting continuously. She was treated somewhere by some GPs also, or then afterwards they come directly to Vasant. Vomiting is not controlled. And when the patient is not relieved with regular medications, and when a sonography is done, and then patient is 16 weeks, 14 weeks, and that happens to the age of 12-year child, 13-year girl. And it is such a distressing thing that 13-year girl is 12 weeks pregnant. And that then it channels of our mind, why, how it is and how to do. And now with the stringent legal laws which have come into it, that is the biggest problem. How to treat the patient, how to address the issue, how to talk to parents, how to talk to that 12-year girl or a 14-year girl, how to talk to them. So these are the things, and very, very delicate and very sensitive issues. So now moving to our topic, and one more example which I want to quote is, one girl was brought long back, 15 years back. She was pregnant and she was brought to us. She was just 14 years old and she was 16 weeks pregnant. Then after, they knew she was pregnant. And after investigating all, she's pregnant, what is hemoglobin, everything, then I took the girl into confidence and I talked to her, how it happened, has someone forced upon you or something like that. So after long talk, what she said, मैं स्कूल जाती हूँ मैडम, मेरा एक फ्रेंड है, स्कूल में सब लोग रहते हैं, फिर जब घंटी बज जाती है, जब सब घर से स्कूल से चले जाते हैं, तो मैं और मेरा फ्रेंड स्कूल में रुक जाते हैं. And there the incidences occurred consensually. So can we imagine when we are sending our children to school with full confidence and that school become the place for all those activities? Then I was really shocked. I connected with the principal of the school, which was in my near locality. They said, Madam, really, whole staff sees all the classes are empty, but still, I don't know how these students, the pupil stay back. And these things are happening. And then we gave a notice to all the surrounding school, keep a staff and check that every student, they go out of school and they're not, because there's no one in the school, offense school or over. So with these cases, let us move towards pregnancy. So sexuality is a total expression of who we are, and it is more than just an act. And it includes physical, emotional, and spiritual part. Sexuality is constantly evolving as we grow. And adolescent sexuality is changing as adolescent nowadays, they attain menarche at a very early age. So they become sexually active very early. There are some conflicts in sexuality, like younger age of menarche, longer time period between sexual maturity and marriage. So they are indulged in sexual acts, urbanization, industrialization. Then some traditional cultures, erosion of traditional cultures, lifting of inhibition of premarital sex. It has become common nowadays. Then sex as taboos in families, so they can't talk to their parents, and they are taking, education, sex education or sexuality education from not a right sources. So they are getting wrong messages, not able to rely on intergeneration relationship. Because many of the teenage pregnancies which come to us are inside the family, from the dear ones, and we are very shocked to know that who is the culprit. So in all of our adolescent talks, we always tell the girls, now, never share a bed with any male person. Whosoever it is from your family, never share bed. You should be with your mother, with your friend, or you should be alone. These are the things we always tell them in our lectures when we go and tell them about the life skills. Then sexually explicit material which are bombarded on internet and social media. So again, they get wrong messages and they indulge into sexuality, and the pregnancies are seen. And liberal sexual behavior shown on TVs, movies, internet, or Netflix, and definitely peer pressure. Pressure of proving themselves, are they complete or not? Is there any concern? Let us take a chance, and they indulge, and then the consequences are there. So what our concerns are, because of this sexual behaviors, there are chances of teenage pregnancies. They land up into unsafe abortions. Adolescent contraception has to come into play. Then STDs and cervical cancers because of HPV infections, psychological impacts, and sexual abuse and violence. So here I will be talking more about teenage pregnancy, unsafe sex, and contraception. The rest of the things will be discussed, I think, in the coming panel discussion. So this has a very serious implication on maternal and child health, especially in the developing countries. So teenage pregnancy refers to pregnancy between 10 to 19 years. That is occurring between age of 10 to 19 years. While pregnancy can occur during adolescence, it is generally recommended that individuals delay pregnancy until they are emotionally, physically, and financially ready to raise a child. And it can happen even before menarche if first sexual intercourse takes place even before menarche. The significant global issues with various social, economic, and health implications. Its prevalence varies according to countries and more common in developing countries like sub-Saharan African countries, Asian and Latin America. Have generally been declining globally, but it still remains a significant concern. So what WHO says is, as in 2019, adolescent aged 15 to 19 had estimated 21 million pregnancy each year. of which 50% were unintended. And 50% of unintended pregnancy ended up in abortions, and which were unsafe. So I just wanted to tell the parent that 1 in every 4th teen can get pregnant by age of 20. And these unsafe abortion can be the cause of MMR. So globally, 64.4 births per 1,000 live births in 2020, and now it has come down to 41.3 births per 1,000 women in 2023. However, rates of change have been uneven in different regions. Sharpest decline in South Asian and more slower decline in sub-Saharan continent. So 3 out of every 10 girls in US are pregnant before age of 20, and 8 out of 10 teenager father do not marry the mother of their child. Teen pregnancy is a primary reason for teen girls dropping out of school, and 1/4 of teen mothers are already pregnant with their second child within 24 months of their first child. So what are the risk factors? There can be social deprivation, low educational achievement, being in the care of social services, sexual abuse, low socioeconomic groups, having teenage parents, child of a teenage, early parents they'll end up into because they're not care taken properly, poor transition from school to work, mental health problems. Many times they have some psychological problems, and then they are befriended and they are abused, and of course crime. Causes can be teenage pregnancy can result from combination of social, economic, cultural, and individual factors, and especially deep-rooted patriarchy and societal control on women's sexuality. Lack of access to comprehensive sexual education. So this joint education forum has come up to enhance comprehensive sexual education in school, and definitely we will attain what is needed for the need of today. Limited knowledge about contraception, unprotected sexual intercourse, early initiation of sexual activity, poverty, gender inequality, child marriages still rampant in India, inadequate healthcare services. In some cases, it may result from sexual abuse and exploitation. So consequences can be physically, on the mother. The pregnant adolescent can face higher risk of complication during pregnancy and childbirth compared to older women. They may experience inadequate prenatal care because pregnancy is diagnosed only in the late stage. Then it's so late that they can't have abortion facilities and they have to carry the pregnancy. They're late in seeking medical advice, which can affect health of both mother and the baby. Psychologically, it may experience high level of stress, depression, anxiety due to demand of parenting at young age. And they may also face social stigma, isolation, and disrupted educational opportunities, which can impact their future prospects. Even the family suffers. Any family having a girl who is pregnant, she is not married and she is teenage, whole family, siblings, everyone suffer, and it has a bad psychological impact on the growth of the family. Then the children born to adolescent mother may again have their own problems. Morely, they are premature, low birth weight, not cared for, so they can have long-term health issues also. They may also have reduced access to healthcare, education, and social support. Now, several factors contribute to adolescent pregnancy, like lack of comprehensive sexual education, insufficient knowledge about sexual and reproductive health, and including contraception and safe sex practices. Limited access to contraception. So there are very good basket of contraception, but those adolescents, they are not taught about it. They are hesitant to get it. They even can't. So the worst part is they can't even talk to their parents about what contraceptions are available. If by chance they get some oral contraceptive, or they get some barrier method, they get some condoms, they even don't know how to use them. There is one joke I can say where a man was explained how to use condom. Condoms were given to the patient, to the husband, and he was told, "P a condom, you have to apply it like this." This fellow was using condom on the finger, And this is how ignorant and how illiterate our people are. So there is barrier of cost for getting contraceptives, and what are available, they don't even know that they are available freely. This information has to be reached to the adolescent as well, and limited access to contraceptives can prevent adolescents from using effective birth control method. Then socioeconomic factors, poverty and low educational attainment and limited opportunities can increase likelihood of early sexual initiation and unintended pregnancies. Peer pressure, as I mentioned, adolescents may engage in sexual activities due to peer pressure, curiosity, and desire for acceptance. So they should have good relationship with their parents or someone keen to them, where they can make right choice and act responsibly. Then gender inequality. Societal norms that perpetuate gender inequality and including early marriages and limited decision-making power for girls can contribute to adolescent pregnancies. Without their will, they have to indulge in the act and they become pregnant and they have to suffer, silent their suffering. Teenage pregnancy can have various negative consequences for both mother and child. Mother can be have high-risk patient. During pregnancy and childbirth, she can have more complications like preterm births. She may be already anemic, then she can become more anemic. Low birth weight, she can have PIH, and she can end up into pre-eclampsia or eclampsia as well. Less than 18 age is more prone for eclampsia and seizures. Lack of prenatal care and delayed medical attention can further impact their health outcomes. And these patients are generally unbooked cases and they come suddenly in labor, and they're really, the complication rates are higher in unbooked patients. Many times they deliver at home, and again increasing on the complication for the baby and for the mother. Now, lack of antenatal care. Teenage pregnant teens are at risk of not getting proper care, and prenatal care is critical, especially in first month of pregnancy. She has not had any folic acid or any supplements. Her iron stores are not taken care of, and then they can have defective babies. There can be neural tube defects or some other birth defects. She can have high blood pressure early in second trimester, and this they are at risk of preeclampsia. The premature birth, early babies born with more risk, with respiratory, digestive, cognitive, and other complication. And teens are at higher risk of low birth weight babies. Medical consequences of teenage pregnancies. Because of poor antenatal care and delayed intrapartum care, fear of reporting underprivileged patients, higher incidence of anemia, hypertension, and they can end up in hemorrhage. And even postpartum care is not sufficient, and they can come with puerperal sepsis or puerperal endometritis, lactation failure. They can come in obstructed and prolonged labor because of underdeveloped pelvis. Then apart from obstetric causes, they can also be at risk of getting STDs, sexually transmitted disease. For teens who have sex during pregnancy, STDs such as chlamydial or HIV infections are major concerns. They can also have postpartum depression because of the psychological pressure which they have about the pregnancy, about the family trauma, about upbringing of the child. And sometimes they have some threats from the family. Even family debar them. They don't accept the patient who is pregnant. Then these girls who become pregnant, their education is suddenly stopped, often disrupt their education and limit their opportunities for further studies. Many adolescent mothers drop out from school due to social stigma, lack of support, and financial constraints. And this can perpetuate the cycle of poverty, dependency, and hinder their ability to secure stable empowerment later in life. Then social and relationship consequences. Adolescent pregnancy is often stigmatized in many societies, leading to negative social consequences for young mothers. And it can strain relationship with family, with their dear friends also, and with their partners. They can face judgment, discrimination, and isolation. This stigma can adversely affect their mental well-being and overall quality. And definitely, you all know better about the child development. They will have, there is increased mortality, poor health outcomes. Now, how can we reduce teenage pregnancy. So proper counseling is important. If patient come at time, how can we counsel her for having proper pregnancy outcomes, proper abortion facilities? Now here, something I want to talk out of, out of the requirement that we can't prescribe contraceptive to this teenage patient, because if we prescribe, it becomes that we are promoting sexuality in these children. So we can't prescribe them contraceptive pills or emergency contraceptive. This is the gray area where we need to work really. IIP and Foxy people have to work how to help these people and how to prevent them from getting it. If they come with pregnancy, again, if they are less than 18, again, it is a role, legal issues come into work. Then looking after nutritional needs of teenage patients, correction of anemia, and treating institutional deliveries. So apart from all these things, many protective policies are already in work, like the Prohibition of Child Marriage Act, which came in 2021, where minimum age of marriage was increased from 18 to 21, then expanded the access to safe and legal abortion services. Medical MTP Act, which was amended in 2021, now increased gestation limit to 20, and now with special permission, we can go up to termination of pregnancy up to 24 weeks in case of survivor of victims of rape or victims of incest or vulnerable women with or some babies with some anomalies. Then MTP is extended services irrespective of marital status, whether she's married or unmarried, she can take, and everything is under, it's not made open to public. Promotive policies like adolescent education programs about body image and gender and STDs, and adolescent reproductive and sexual health strategies have come, which create preventive and promotive and curative services for adolescent. And adolescent public OPDs are made. Adolescents may not understand the science of pregnancy is again an issue. They should be made aware of the existence of safe abortion techniques, legalities of abortion, and location of abortion center. Now, a word about unsafe abortion. See, this is not preventing teenage pregnancy, but how we have to save our teens. Because of unavailability of services, because of legal issues, these teenagers fall in hands of unsafe abortions, which is the third leading cause of maternal death in the countries and contribute to 8% of all such deaths annually. Nearly 6.4 million pregnancies are terminated every year in India, and as per WHO, around 7 million women are admitted in the hospital as a result of unsafe abortion. So her abortion is done and we can lose the life. Every 8 minutes, a woman in developing country dies of unsafe abortion. And of those who survive unsafe abortion, they can suffer from long-term health complications. So WHO deems unsafe abortion one of the easiest preventable cause of maternal mortality. So how can we decrease teenage pregnancy? So barrier to safe abortions should be removed. So restrictive customs and law have to be broken. Obsession towards having a male child, poor availability and accessibility of service, the stigma and the high cost and objection of healthcare providers should reach the person who needs. Unnecessary requirements such as mandatory waiting periods, mandatory consents, then misleading informations or unnecessary tests will delay the person who is in need of service reaching the person who is service provider. These delays or these things where they can be lost to come to an appropriate person should be made short. Asking for unnecessary concern, even if adults, should be it should be worked on. We should be given some importance. And easy availability of abortion pills should be made definitely with patient-friendly norms. The contraceptive effects, or even the emergency contraceptive. Emergency contraceptive should be made available. Again, we can't prescribe, but as all pediatricians, you should know that you can use emergency contraceptive where combined oral contraceptive or progesterone only pills can be given within 72 hours of unprotected intercourse, 12 hours apart, 2 tablets have to be given. 2 tablets stat and 2 tablets after 12 hours. You can use combined oral contraceptive or progesterone only contraceptive, which are easily available in the market. This has to be given to the teenagers. And again, we have to tell them that this is not a method which has to be used frequently. Nowadays, adolescents are indulged into sexual acts so commonly and so frequently, they are using emergency contraceptives regularly. So emergency contraceptive is to be used in emergency if they meet once in 2 or 3 months or or even say in annually or in a 6 month, and they use it repeatedly and their cycles are disrupted. Already the incidence of PCOD is already high, and this can lead to it can disturb their menstrual cycles and all hormonal imbalance. One more very important aspect is any patient who is nowadays pregnancy kits are easily available and they are smart enough. If they miss their period, they do their urine pregnancy test, and by some hook or crook or by befriending some pharmacy person, they get those pills also. They consume these pills, and you know what, many patients we have seen that without knowing the status of the pregnancy, whether it is intrauterine or ectopic, they consume these pills, and then we get many unmarried ruptured ectopic pregnancies in shock. And then one patient who came to me, she was in full-blown shock and her hemoglobin was 2 grams. She was just gasping. They never knew, distended, bloated abdomen, and she was just pale, and she was ectopic, unmarried girl with ruptured ectopic pregnancy. So again, monitoring is very important, and to go through proper channel is very important. Just because it's convenient and easily available, emergency contraceptive should not be promoted that way. Parents of adolescents should be aware of this method, and they should be willing to advise their youngsters. See, we can't stop this generation from indulging in sexual act. As we know, it is a natural instinct, but we should make them smart enough. They should not become pregnant. Now, this is American Academy of Pediatrics, which has brought up consensus for contraception use. But here, I just wanted to emphasize on point number 4. Adolescents should be allowed to consent to contraceptive care, and pediatrician should support and protect such consent and confidentiality within the limits of state or federal laws. Then, 8th, adolescents with disabilities and chronic illness have sexual health issues. The contraceptive needs similar to healthy adolescent, and these adolescents with some disabilities are again victimized. So really we have to look to them also. One more thing is that allowing a sufficient time during clinic visit to talk to adolescent about the contraceptive practices, about their sexual indulgence or their what problems they have, will definitely help in reducing teen pregnancies. So one more thing which I find many times, menstrual history has to be added into for every patient, any girl who is more than 10 years of age, because nowadays the age of menarche has come down. So just inquire for their LMPs. Now, these are contraceptive which can be given, low dose contraceptives which can be given to these girls if they want, without any side effect, because many of the girls are nowadays having PCODs or some menstrual irregularities and other problems. So they are already given low dose pills. So they can be on hormonal contraceptive. Barrier method can be the best. It can give them protection against STDs as well as of pregnancies. High failure rate is there. We should tell them how to use, how is it used, and how it can prevent them from STDs also. Nowadays, we recommend dual protection and dual method use. So dual protection is, while they are using barrier method, they should also, sometimes there can be slippage or sometimes it is not used. So they can use a supportive method. And dual method is, this involves always using a condom plus other methods of contraception. So low contraceptive can be used to reduce failure rates. And ideal contraceptive which a adolescent can have is which should be highly effective. It should have little or no risk to her health. It should be independent of any compliance. It should be easy to use. It should have no negative impact on their body image and appearance, which is very important for them. They don't want bloating. They don't want weight gain. It should be good for their bone health. Their fertility should be preserved and it should come back whenever they are using, and it should protect them from STDs. An additional benefit to help with frequent conditions like bleeding irregularities, dysmenorrheas, PCO syndrome, and acne. Now the legal aspect. So marriage below 18 years for female and less than 20, more than 21 years for male. And the MTP Act abortions rules have come. Then the child helpline number is there, 1098, whenever they require any help. Then POXO Act in 2012, which is a comprehensive law to protect child from sexual offenses. What does this POXO Act says? It says a pregnancy in less than 18-year girl, unmarried girl is considered as a rape. So here the joint forum is already working and so many things are working, but our hands are tied with the laws and we have to follow it. Even if consensual sex less than 18 years is statutory rape. If she is married less than 15 years, if pregnant, it amounts to rape. Now, married between 16 to 18 years, if pregnant, now here, it can be rape. It should be considered rape. So IPC 375 is under consideration and they are working over it. So Supreme Court judgment has been given that inform police in all above situations and keep on giving your treatment. So a few years back, we were very hesitant, all the gynecologists, a patient who is 14 years, 15 years and UPT positive, we were under stressed. How to do? Because the first thing to be done was just to inform police. They will take care of. What happens many times, these patients, they come to private sector. No? They don't, because of, they want to hide the identity. They don't want it to get public. They come to private practitioners and once they come out, they come to any doctor for that reason. And we inform police. So they have come to us to hide their identity and we are informing. So this is a very, very sensitive area, but we have to inform. Nowadays, things are coming up, easy. Once we inform police, we get the buckle number on our complaint and then we give them primary treatment, whatever is to be given. And then many times, this patient is taken for treatment to the government center, but we are also treating nowadays. That is that has made things are becoming easier than past years.
Pragati ji, time.
Yes. So overall, addressing adolescent pregnancy requires education, healthcare and social intervention, non-judgmental approach, comprehensive information and reproductive health education is important, along with emotional support and involve parents and guardians. Postpartum checkups are very important. So there we can tell them about contraceptive advice and psychological support. One more very important thing which I wanted to press upon is many times the patient comes late in pregnancy where we can't provide her with abortion facilities. We should tell them about adoption facilities. There are very many good centers where these babies are taken for adoption. So we can look into that. And in conclusion, adolescent pregnancy is a complex issue, far-reaching consequences for individuals and societies. So by addressing the underlying factors contributing to adolescent pregnancy, we can work together in reducing the burden. Thank you.
Excellent, Pragati ji. It's a very big topic and thank you. You have covered it so well.
Thank you, Pragati. Very nicely covered and very practical and very informative. That was the best part. And we really enjoyed your session. And we didn't even realize, we were so absorbed that, okay, we are going a little ahead with the time. And then suddenly I also looked and Hema also kind of nudged in. So that is what, anyways, should we be taking some questions or we should leave it for the panel to be some questions and then
we can take the questions later, madam. Even the youth may be asking. So she'll be with us. I already told her she'll be with us. So
so she's going to be with us. Yeah. And Dr. Pyali will be starting off with as a moderator for the panel discussion, and these questions can be taken and they can be nicely handled. So I think we need to move further.
Yeah,
that is fine. Dr. Arya. Perfect. Thank you very much.
Thank you,
so
Sangeeta
much
madam,
for the
for
opportunity.
chairing the
Thank you so
session
much.
nicely, and thank you, Pragati madam. आपने बहुत अच्छी तरह हम लोगों को है ना अपने नॉलेज से बताया. Now, move on to a panel discussion. The common adolescent gynecological problems. Our moderator of this panel discussion is Dr. Pyali Bhattacharya ma'am. She is DCH, MD, FIAP, FRCP from London. Presently serving as pediatrician, General Hospital, SGPGI, Lucknow, UP. She graduated from BS Medical College, University of Calcutta. Post-graduated DCH, MD Pediatrics from KGMC, Lucknow, UP. Awarded fellowship in pediatric FIAP 2015, FRCP from, in
Prakash, let us
2019.
proceed with the academics, I think.
Right,
na?
right,
think
madam.
best
बस
thing
right,
to
madam.
introduce
Sorry, madam. बस थोड़ा तो
Dr.
बोलना पड़ेगा.
Pyali. Dr. Pyali is the president of UP chapter and
Right,
she's
right,
one of the
madam.
most vibrant members of our AHA. Over to you, Pyali.
Thank
Thank you, thank you so much. So, today's topic. Can you see my slides?
Yeah, madam.
Slide show कर दीजिए.
So, आज तो we have such eminent speakers, and at first I must congratulate Pragati at being present with us and you've presented such a beautifully this thing now, all the contraceptives and teenage pregnancies. Yes, we were aware, but the statistics that you've given are awesome. I mean, I did not know that so much of teenage pregnancy is happening. So now, having said that, let us start with our panel on adolescent gynecological issues. I have very eminent panelists today with me, Dr. Usha Banga, Dr. Lakshmi Shanti, Leenatha Reddy, and Priya Amitabh. So, what we want to know or want to tell or apprise everyone is that menstruation and menstrual issues are basically a taboo in India, and we've been keeping that as a taboo in our society. Maybe in the middle class or the upper middle class, maybe we have come up with a less taboo, but in the lower class and the lower middle class, the taboo still persists, you know. Ganda hota hai, periods are impure. You isolate yourself, don't stay with others. You restrict your activity, don't go into the company. Silence, it is don't talk about it. Shh. It's very shameful. And sometimes along with it, there is school absenteeism, school dropouts, etc. The impact actually goes on to the mental health of the adolescent. There is anxiety, there is low self-esteem, goes to the physical health of the adolescent. There is poor hygiene, issues of STIs, and goes on to the education and missed opportunities and empowerment of the children, that is the school dropouts. So today we must change the scenario. The changing scenario is already occurring. Most of you must have seen that film called Padman. And then there are many NGOs, many people who are distributing free pads. We are talking about menstrual health education. A lot of talk is going on. In fact, today we are talking is that the taboo is gradually in the changing scenario. Today's agenda would include vaginal discharges and STIs, menstrual disorders, PCOS, and menstrual hygiene. I will invite my first panelist. So she is a PGDAP. She's a specialized child and adolescent health specialist from Coimbatore. And she has been a part of various modules of AHA like MKU, AYA, MSU. And she is also doing a lot of community outreach programs with various NGOs. She has publications to her name in very, very precious books like IIP Book of Adolescent Friendly Pediatric Practice, IIP Textbook of Adolescent Medicine, and AHA Coffee Table Book. So, Dr. Lakshmi, this is a case for you. 15-year-old brought by her mother, complaints of easy fatigability for the past 1 to 2 months, erratic eating behavior, improper sleep, under constant stress because of her board examinations. Complaints of white discharge. She says, Auntie, मेरा ना panty में stain हो जाता है, white discharges हो जाते हैं, more than 2 weeks हो गए, जाता ही नहीं है. The menstrual period history says that she is regular. So how would you proceed?
Good evening, everybody, to all the esteemed seniors, colleagues. Thank you, Pyali ma'am. And Vanakkam to all my fellow pediatricians who joined from Tamil Nadu. So coming to this case, this adolescent girl, 15-year-old girl, we can all identify her as a prototype girl whom we see in our adolescent practice. A girl who has been an introvert, a very cherubic girl who has been very active in her academics and sports. And suddenly when she reaches the 9th grade or the 10th grade, the stress begins to catch up with her. Given to parental expectations, peer pressure, and all these school academic issues create a lot of stress on her. And here she is with us with a physical problem. So we have to understand that stress in this age group, in the adolescent age group, can give rise to both physical and mental issues. So though this white discharge may not be a direct indicator of a stress, but stress plays an important role in such simple physical symptoms, which we see in our adolescent cases. So for this girl, in addition to the routine HITS assessment that we do in our adolescent pediatric practice, I gave emphasis to the menstrual history and also to the sexual history. So the menstrual history, she said, as we saw earlier, she said the periods were regular, and what type of napkin she's using, whether it is a menstrual cup or a tampon, all these history needs to be taken because we are dealing with an issue of vaginal discharge. And again, sexual history is also very important because we saw Pragati ma'am talking about teenage pregnancy, and it is high time we need to talk to our adolescent girls and boys about sexuality and their sexual debut. So after all this history is taken, and then we approach the girl. So coming to this girl with vaginal discharge, first we as an adolescent pediatrician need to understand what is white discharge, whether it is normal for that age or is there something pathological in it. So what is leukorrhea, which is the common term that we use for white discharge? The normal premenstrual and the postmenstrual genital tract transudate is called leukorrhea. It is nothing but the desquamated epithelial cells and mucus from the estrogenized mucosa. So we all know that vagina has the columnar epithelium, which as influenced by the estrogen hormone turns into the squamated epithelium. And this the glands that are present in the walls of the vagina called the Bartholin glands secretes this mucus, and along with the bacilli, which we call the lactobacilli, the Dodeline's bacilli that we call. So all this comes as a discharge, which acts as a lubricating and a cleansing discharge for the vagina. So vagina is a self-cleansing organ. So this vaginal discharge is physiological in most of the cases. So the physiological discharge is a whitish mucoid discharge, and it starts before menarche. So somewhere like 6 months to 1 year before menarche, this vaginal discharge starts in an adolescent girl, and it has a cyclical variation. Because it comes under the influence of estrogen, we can see a surge during the ovulation period and also pre and post menstruation. And when do we call it pathological? So we already saw that most of the vaginal discharge is physiological. So when do we call pathological? Pathological leukorrhea can be due to many reasons like vaginitis. It could be bacterial, fungal, viral, and it could be cervicitis, or it could be a foreign body, or allergic causes are also very prevalent in adolescent teenage girls, and STI, which is a topic by itself. Yes, ma'am.
So, Lakshmi, can you identify a leukorrhea, whether it is pathological, by the color of the discharge? Can you do that?
Yeah, so a simple, history, after the history taking and HEDS assessment, a simple clinical examination of the child and an external examination of the genitalia. We are not supposed to do a pervaginal examination in an adolescent girl. But if needed, if there is a pain or associated symptoms, we can do a speculum examination. But before all this, from the history taking itself, we can find out from the adolescent girl the color and the nature of the discharge, when it is more prevalent and things like that. We can ask the girl, like, how does the discharge, like we can ask her to compare it to a, mostly we call it a sticky substance, which is white or mucus in discharge, or the color of the thing, whether it is foul smelling or malodorous, or whether it is sticky, and all those things we can ask. So this is a simple vaginal discharge color chart that we can use with our adolescent girls and ask them the color of the discharge that they have. So as you see in this chart, a clear discharge can be healthy. It can also be seen in pregnancy, ovulation, and hormonal imbalances. If it is white, it could be healthy or it could be a candidal infection. If it is yellow or green, it indicates that the child might be having a sexually transmitted infection. And we all know that if it's red, it could be menstruation, but a cervical infection, which is cervicitis, can also give a red discharge. And if it is pink, it could be fresh bleeding from the cervix, vaginal irritation, or implantation bleeding. And a gray discharge, which has a fishy odor, is very characteristic of a bacterial vaginosis.
Thank you. But then tell me, what are the tests required in such cases?
So most of the diagnosis is done with the history and the clinical examination, whether we can see the vagina, any redness or soreness is there, and the nature of the discharge and things like that. But there is a simple test that we can do in our office practice by testing the pH level of the discharge. So we have to know that the vagina has an acidic pH. The pH of the vagina ranges from 3.8 to 4.5, and this acidic pH is what keeps the vagina healthy and prevents it from all the other infections. So this pH of the vagina has to be maintained at all levels. And this point of care testing, testing the vaginal pH, it's also done as a self-care kit. The patients themselves can do it. And if the vaginal pH is less than 4.5, it is suggestive of candidiasis, and a pH more than 4.5 is suggestive of bacterial vaginosis or trichomoniasis. For this pH testing, we take just a swab and take the discharge from the lateral wall of the vagina and just put it on the pH paper and see whether it is less than 4.5 or more than 4.5. And in advanced situations, or if there is a recurrent or a chronic discharge, a high vaginal swab for microscopy can also be done, which we basically, pediatricians, we don't do, but the gynecologists do. And it is done in a wet mount, KOH mount is what we call, and also a gram stain is done. And culture and sensitivity can also be considered if the adolescent has a chronic or recurrent symptoms. And if there are other systemic symptoms like pelvic pain, fever, and pain during micturition, dysuria, and all those things, then an ultrasound abdomen is also warranted.
So Lakshmi, what should be the clinician's approach to vaginal discharge? Child comes to you.
Yes, ma'am. So as far as we pediatricians practicing adolescent health are concerned, the most common scenario that we come across in our practice is an adolescent girl coming with a vaginal discharge, which is most often physiological. So just reassurance and giving her some anticipatory guidance and hygiene, which is very important. So all these things would be enough. But we also have to be aware of the fact that there can be pathological leukorrhea, and we have to identify certain things when it could be pathological. And in pathological leukorrhea, the most common cause of pathological white discharge is a bacterial vaginosis, which is commonly seen due to unhygienic situations or certain other practices. So in this bacterial vaginosis, the discharge itself gives a clue, as we saw in the color chart, the grayish discharge with a fishy odor. And if the pH is more than 4.5, we already saw it could be a bacterial vaginosis or trichomonas. So trichomonas and all the other things like gonorrhea and lymphoglanum, all these come under a class called the STI, which we should keep it in mind. But if we suspect those cases, it is better that we do the proper tests and refer them to a specialist. And pH more than 4.5 could also be due to contamination with cervical mucus, semen, and menstrual blood. And in saline microscopy, in bacterial vaginosis, we can see what are called the clue cells. Clue cells are nothing but the squamated epithelial cells that are almost filled with the coccobacilli, so that the cell's margin become indistinct. So these are called the clue cells. And in trichomonas, a simple microscopy will show the darting motility of the trichomonas vaginalis that we can see in the microscope. And in candida, the yeast cells and the pseudo hyphae can be seen, which is better seen with the KOH mount. And gram stain again shows the clue cells.
Right. So we'll go a little fast. What about the prevention and the treatment in such cases who come with vaginal discharge?
So the commonest thing that we face are the bacterial vaginosis and candidiasis. So candidiasis, we can use some local antifungal creams like clotrimazole. And we also should take care that we shouldn't use the steroid combination with clotrimazole, but that can again lead to other problems. So a simple clotrimazole or other antifungals can be used, and a single dose of tablet fluconazole, 150 milligram. And for bacterial vaginosis, metronidazole or tinidazole can be used for 7 days. If they're not tolerating, the latest ornidazole and clindamycin can also be used. And for STIs, it is totally, a different topic and beyond the scope of this thing. And for STIs, partner treatment is very mandatory. And we also do a regular deworming for these children. And prevention is more important in such cases. And the anticipatory guidance that we give as an adolescent pediatrician is very important. First thing, the good hygiene. They have to maintain a good hygiene in their private areas. And breathable clothing, wearing soft cotton underwear is very important. Staying hydrated, balanced diet, and avoiding vaginal irritants like douches, bubble baths, perfumed soaps and creams. We have to take all this history. So these can be irritant, producing the white discharge. And it's better to use cotton pads and tampons. And sometimes you also remember that retained tampon could be the cause of the vaginal discharge. It's like a foreign body. And also removing the sports clothing after exercise, like the wet clothing after the exercise, is also very important. And the vagina is a self-cleansing organ, as I already told. So there is no need to clean it with harsh chemicals and soaps, which is very important. We have to tell our adolescent girls.
So when do they need to seek help? When do they need to go and see you?
Yes, ma'am. So when there is an unusual discharge which is persistent and present for a long time, which is thick, foul smelling, green or yellow in color, associated symptoms, as I already told, systemic symptoms, persistent discharge. If we suspect an STI, then we need to the history of sexual abuse is also very important, because we have seen, in media, we see day in, day out cases of girls being raped by multiple gang rape and things like that. So this history is very important if we are suspecting an STI.
Okay, so thank you. So can you just sum up a syndromic approach to the STIs? Because this is very important. We get frequent STIs. So you will have to sum this up.
Yeah, so this is, I don't want to go to the depths of STI because it's a big topic. So this is one color-coded kits that are available in the government sector, and it is an initiative under the National AIDS Control Program. So the different colors, like the gray color kit is will deal with the urethral discharge, vaginal discharge, scrotal swelling, etc., which contains azithromycin and cefixime. So every color has a coded to one syndrome. The thing behind the syndromic approach is because the etiological diagnosis is not possible like most of the time in STIs, and mixed infections are common, and lab diagnoses are also not much sensitive and specific.
Correct.
So this is the reason behind this syndromic approach in STI, which is freely available in all the government centers.
So does this STI also affect fertility, Lakshmi?
Yes, ma'am. It can affect fertility in the future. So we need to make the adolescents aware, and we need to educate them about safe sexual practices and contraception, as said by Pragati, ma'am, because the adolescent, the unmet contraceptive need is more in the adolescent period.
Thank you, Lakshmi. So what Lakshmi says is that leukorrhea is often a normal part of vaginal health, but staying informed and attentive to changes can help early detection of potential issues. So thank you, Lakshmi, again. Let's pass on to Dr. Usha Banga. Dr. Usha Banga is Director, Prayas and Astha Hospital. She's also a consultant pediatrician and adolescent expert. She has authored 2 books and is frequently writing columns in papers, several stories, which I've also read, excellent stories she's writing. And she has research on lead toxicity. She has also been editor for Adolescent Today, Impact, Harmony, and she's also been the past president of IIP Gwalior. So, madam, the first question goes to you. What is normal menstrual cycle? And when would you call it abnormal?
Thank you, Dr. Piali. I would like a few words that because of psychological concern, adolescents do not want to see gynecologists. So we pediatricians have a duty to deal with all these problems. Menstrual cycle normally should occur every 21 to 45 days and lasting for 2 to 7 days with an average blood loss of 30 to 40 ml blood, requiring use of 3 to 6 pads or tamponade per day or 10 to 15 soap pads or tamponade per cycle.
So when
That
what are
is
the
normal.
causes? What
Yeah.
is the causes? If it does not conform to this pattern, that means you will call it abnormal. So
Abnormal,
fine.
yes.
So what are the causes then of abnormal bleeding?
Most common cause is ovulatory dysfunction because of the immaturity of hypothalamic pituitary ovarian axis, which we all know. Another leading etiology is various coagulopathies, including von Willebrand disease, other coagulation factors, deficiencies, immune thrombocytopenia, platelet dysfunction. I have seen that we normally don't ask about these things. And less frequent causes are pregnancy, which we have just seen, the teenage pregnancy. We should always do the pregnancy test in every every menstrual problem. Sexual trauma is one very important cause of, we can find out whether there is abuse or something. Sexually transmitted disease, infection should also be taken into account in the diagnostic process, which we have been discussing recently.
So ma'am, if some child comes to you, what will be your goal of management?
Goal of management should be to find out excessive bleeding, abnormal bleeding. As we know, almost all 80 to 85% cases are normal cases. Only thing, after menarche, first 2 years, there's on most of the cycles are anovulatory and axis is not matured. Because of that, they have irregular menses, heavy menses, or broad, wider gap between menses. But we should find out if there is any abnormal problem, any other syndrome, or anything which we are missing, like some polyp, some growth inside, that we should see. And we should correct anemia. Anemia, as it is very common in our country, almost all the adolescent girls are anemic. Here, I would like to point out one thing, that we should also see megaloblastic anemia at this point to maintain normal menstrual cycle, because it gives too much stress to the teenage. So it should be our goal to manage that physical health and mental health also.
Acha, thank you, ma'am. But then this is a case. A 13-year-old girl comes to the OPD. She has a complaint of continuous, moderate, painless bleeding for the last 22 days. The menarche has just occurred a month back or 22 days back. So is this normal? Is this abnormal? What would you call this?
At this moment, we can say high chances is that it is a normal phenomenon. But
So
we
how
should
would
not
you
ignore
approach?
other things. Yeah. We will take detailed history and examinations. First is CBC, and don't forget to do UPT. Because I have seen, and I will do, I will not ask them for pregnancy test because the girl is unmarried. So they become worried and they say, no, I don't want to do this test. So we just ask our pathology boy for RM and ask him to do UPT secretly and just tell me. And it happens many times. I have seen teenage girls pregnant, and one girl, she came with shock and ruptured tubal pregnancy. Yeah, then I had to send her to hospital. And again, ultrasound is optional. If all of other things are normal, we can skip it. These are the all 4 logical steps. They are cost effective and require little skill and little money.
So, ma'am, what menstrual history would you like when you are taking a detailed menstrual history?
First of all is menarche, a onset of menarche. When did it occur? Onset of abnormal menses, was it sudden or gradual? We must have to see, we should see it. Timing, duration, and quantity of her uterine bleeding. What time or how much it lasts, or quantity, like she has to change her pad every 2 hours, then it is too much. Or it is intermenstrual interval, between two intervals, if she is getting frequent bleeding, then it is abnormal. Cramping and clots or flooding. If she gets too much pain while menstruating, or many clots she is passing, or just a gush of blood is there, then we have to take care, because she may fall in shock, or she may become anemic quickly. And this is very important, which I should say we all must keep in mind. Evaluation of bleeding disorders. Weight changes, eating pattern, and exercise schedule. Eating pattern, because in anorexia nervosa, the girl, they have menstrual irregularities, and the athletes or doing excessive exercise, they can have long periods of amenorrhea. Or if there is weight change, like getting too much weight or losing too much weight, if she's putting on too much weight, then we'll have to see for other hormone conditions. And one is hypothyroid. This is one of the common causes of irregular menstrual bleeding.
So investigations.
In this case, I would like to do hemoglobin. As you know, CBC will do. Thyroid profile is a must. Otherwise, also thyroid is a screening test, so we must do. Coagulation profile, it is normal. Her thyroid profile is also normal. Her uterus is normal in size, contour, and ecotexture. Endometrial thickness is 6 mm, that is normal. Both ovaries are normal, and there is no free fluid.
So this girl is just anemic.
And she's little anemic, yes.
So treatment, what would you like to give to this girl?
There are two types of treatments. Both hormonal and non-hormonal therapies can be given. Grade A and level 4. Like first we should, if there is, everything is normal except anemia, we would prefer non-hormonal treatment. Is the primary option. Tranexamic acid.
Trenexa.
Yeah, Trenexa. 1 gram QID for 5 days. And hormonal treatment, contraceptives, they are secondary option. And progesterone only pills can be used. Here I would like to mention that contraceptive should be deferred till the age of 14 or 16 years, because they can give rise to fusion of epiphysis. We should prefer progesterone drugs only. And reassurance and counseling is an important factor.
So about the estradiols, ma'am.
Pardon?
About the estradiols in monophasic combined or...
Yes. Monobasic combined oral contraceptives with a minimum of 30 to 35 microgram ethinyl estradiol. For moderate bleeding, we will start with 1 tablet TDS till the bleeding stops. Usually within 48 hours. 1 pill BD for 5 days, then 1 pill once a day for total of 8, at least 21 days. Then we'll wait for menses, then again we can start. So usually she may need 2 to 3 cycles for the treatment. In severe bleeding, we have to give injections, estrogen, 25 milligram, 4 to 6 hourly. We may admit the patient. 1 pill QID till the bleeding stops. 1 pill TDS for next 3 days, then 1 BD for 2 weeks. Then we can evaluate further the girl.
Thank you, madam. So what is important is education, making them aware and educated about the issue. So what education to the patient and to the parents?
Yes. In every medical problem, in medical science, education is the key to prevent things, to prevent worry, to keep mental health of the patient and parents okay.
Correct.
Emphasis should be on maintaining a menstrual calendar. She should always note, because people tend to forget what was the first date, then it started. Emphasis on correction of anemia and good health. It will also prevent irregular menses. sometimes in anemia cause bleeding. Explain about optimizing weight. As we all know, obesity has become like a pandemic. All the developed countries, now in our country, in upper class, in affluent class, we are getting obesity patients. Evaluation, counseling, and management of breakthrough bleeding. We should tell them clearly. Explain risk of endometrial cancer in endometrial hyperplasia and PCOD.
So, madam, having said this, so what about those patients coming to your OPD? Do they confirm or are they consistent in their treatment?
Mostly, actually, I have seen that after if they get too much problem, then they prefer to go to gynecologist. And they are not much consistent.
So,
And
Pragati
when
madam
you-
wins over there.
Pardon?
Pragati madam wins over here. The patient
Yes,
prefers you.
yes.
Dr.
Yes,
Piali, can
we have to, yeah, take help of Dr. Pragati.
Dr. Piali, time thoda sa manage.
Yes, I'm trying. Dr. Leena, are you here?
Yeah, I'm
So
there.
my next panelist is Dr. Leena. She's a senior consultant pediatric endocrinologist at Children's Hospital, Hyderabad, Rainbow Children's Hospital. And she is a very prominent faculty over there. She is the diabetes specialist. She's co-organizer to the pediatric diabetes for postgraduate interactive workshops. She's founder member and ex-secretary of the Thalassemia Support Foundation. She's done a very big work in thalassemia as well. So, Dr. Leena, welcome. And this is a case, 15-year-old. She has presented with increased weight, hirsutism, and amenorrhea, acne, acanthosis. Now, this is the case. So, how do you identify this case? And in one look, she's a spot diagnosis. How do you identify her?
Well, for me, I mean, the first thing that you think about is because of the severity of her clinical features is PCOS, but also you think about late onset CAH. But also one has to think, remember that a lot of girls during adolescent phase will go through some of these changes which could be just part of normal puberty. But in this case, because of the severity, I would be a bit more concerned and evaluate further.
So, what is the possible differential diagnosis? As you say, it could be CAH or hyperprolactinemia or an abnormal thyroid profile. So, what is the criteria that you would set for PCOS, as you say?
So you have to be careful when you're making a diagnosis of PCOS in an adolescent. It is not you don't rely on the same criteria as you do for adult women with PCOS. Here, an ultrasound scan is of no value, and there are a lot of guidelines which will actually tell us that ultrasound scans is of not of much benefit until at least 8 years post menarche. But I'm not completely sure about that. In general, it is based on just two criteria, and both those criteria have to be fulfilled. And that is, the first criteria is having irregular cycles. And again, as already mentioned by Dr. Usha, irregular cycles, again, adolescents, once they've attained menarche, the first 1 to 3 years, they can have anovulatory cycles. So their cycles will be irregular. But there is a criteria for it. So if in the first year, they're allowed to not have a cycle for up to 90 days, while after the first year, that is between the second and the third year, it usually, again, you can wait for up to 45 days before you can say, or under 21 days before you say it's irregular. And after 3 years, it is just like an adult, where we say if your cycles are less than 21 days or more than 35 days, then it is counted as irregular. Now, if they fit into this box, along with features of hyperandrogenemia, that could be either clinical or it could be biochemical. Most of the time it's based clinical. If not, we wouldn't evaluate further for biochemical evidence. And clinical is acne and hirsutism, and how significant that is. Based on that, you make a diagnosis. Now, it's not always easy to make a diagnosis. It's not necessary to make a diagnosis. If the features are significant, it is affecting the child, then you have to consider treatment at whichever stage they present to you.
In such cases, what are the investigations that you would consider?
Again, the first thing when you talk about investigations, it's not easy because you can't do one single test and say, oh, I can rule it out. Do we do it step by step? Again, you have to go by based on how the child presents to you and what are your features and how bothersome are those features for that particular individual. Now, if it's just a little bit of irregular cycles, then you can probably talk to them, see what you can do just by with simple blood tests. But if the child presents the way this adolescent has presented to us, then you probably need to do all the investigations. And you're looking for the first simple thing, check their thyroid profile. Then you're looking for androgen levels, so total and free testosterone. The problem with total and free testosterone is we don't know what are normal for adolescents. So again, you might take a testosterone level and it might still be normal, but there is significant acne and hirsutism. So you will have to again do your DHEAS and 17-OHP and androstenedione. If your DHEAS is significantly raised, then you're suspecting adrenal source of your androgens. In general, in PCOS, it is ovarian androgens which are the problem. You also do your LH and FSH ratio because it's elevated. Prolactin, though very rare, you would consider it because sometimes that can also cause irregular cycles. And most, not all, most adolescents who present with features of PCOS are overweight or obese. So you've got to think about metabolic syndrome. So an OGTT is much more reliable. You can still do a HbA1c, but OGTT is much more reliable. Fasting lipid profile, LFTs. Now, if you do have an elevated 17-OHP or androstenedione or DHEAS, you need to consider doing a synactin test because you want to rule out a non-classical CAH.
Thank you. Then how would you manage PCOS in an adolescent? See, all these will be for general patients. So what more can we do for the adolescent?
See, the very first thing is, I think the whole idea about managing PCOS in an adolescent is one is to help them with their current symptoms, but also for their long-term health outcomes. And the first thing is lifestyle modification. Even if, yes, it's more beneficial for an obese and overweight child, adolescent, because even 5% reduction in their weight will improve their cycles. But what we are also seeing is young adolescents with a normal BMI for having a very a not so good lifestyle. All of them stay up late. All of them have bad habits with their diets. So I think lifestyle, regardless of the BMI, has to be emphasized in all adolescents. And it is the first thing. And I think most of us tend to do that. And that's the only thing we tell our families and ask them to come back in a few weeks with a diet change and lifestyle modification. Now, if it doesn't work, or in case of this young girl who had a lot of significant acne and hirsutism, then you've got to think about the next step. Now, in this, it is combined oral contraceptive pill. We try to take the low dose one as much as possible. Now, this will help with, one is regularizing your cycles, but it also helps with your acne. To some extent, also helps with hirsutism. Now, metformin is the second pharmacological agent that we would consider, and this is more useful if you have an overweight or obese child with abnormal OGTT or an elevated HbA1c. It will help with to some extent with weight loss and improving the overall glycemic control, but not help with the cycles. So if you're having irregular cycles, then you might have to consider a combination of it. Or on rare occasions, we even use anti-androgens. Anti-androgens are like spironolactone, which in combination of metformin, some studies say that it's a better combination. But you have to be careful with all of these drugs because there's not a lot of evidence in adolescents. So if you're using it, you need to make sure that they come back for follow-up. And how long do you use it? You use it for a few months. Generally, we usually use it for about 3 to 6 months and then usually take them off medication, with the hope that most of them would have followed our lifestyle modifications and they would have made their reduce the weight to some extent. It's not always about the weight. It could be your abdominal circumference, and all of that will also make it a lean muscle. Improving your lean muscle and reducing your fat will help. So these medications are used based on the requirement of the particular adolescent. And in this young adolescent, we did use a combined oral contraceptive pill. Initially, we used Diane 35, but then later on switched over to a low dose contraceptive pill.
So, Lena, having said all that, these children are children,
Yes.
So, lifestyle modifications you advise, how long do you wait?
Again, depending upon the age. See, a lot of our parents come even at 6 months saying, ma'am, she's not had a cycle for three months, and that panics them. And in that case, I'm not panicking. I would wait. I would put in lifestyle modifications even for 6 months to a year. because I know that is not counted as irregular cycles. But if the child has a lot of hirsutism and acne, then yes, the picture will change and I'll have to address it according to that.
Dr. Piali,
Thank you. I have just Priya. So I have just Priya left. So Priya, you there, na Priya? She's a senior consultant at Tata Motors Hospital, Jamshedpur. She is a faculty for research methodology and she's also a member of the IEC, the ethics committee. So what is menstrual hygiene and why is it so important? Priya, the first question.
Good evening, everybody, and thank you for giving me the opportunity to speak in this platform. Well, adolescence, as we know, adolescent health till recently was largely a neglected area and ignored area, and compliments to IIP and AHA for taking up this issue very, very seriously and taking this on priority basis. And it's very important today that we've been discussing the adolescent issues today, and especially the gynecological issues and gynecological problems of adolescents. Today, we've been discussing various menstrual problems in by various speakers. They've been discussed. Coming to menstruation and menstrual hygiene, well, menstruation has been a taboo ever since, it's been known ever since the existence of human beings. And it's paradoxical that on one hand, menstruation is a taboo, on the other hand, pregnancy is celebrated, right? So, well, as doctors, all of us know that menstruation is as natural as a respiration. It's just a physiological process, right? It's just all of us know that it's just shedding of a unfertilized ovum along with the inner lining of the uterus and all those things. So why is menstrual hygiene important? Because during menstruation, a lot of things are associated, a lot of taboos and a lot of myths are there that menstruation is cursed, it is dirty, one should not bathe during menstruation, a lot of restrictions are there. So to bust those myths, one should follow certain hygiene. It is very normal and very natural process, and one should be hygienic one should be, and one should be healthy during the menstruation. And that is why it is important to be hygienic during menstruation. One should follow a healthy lifestyle and one should follow certain things. So there are certain criteria, there are certain points that one should follow during menstruation. So these are the points which constitute menstrual hygiene. Number one is managing menstrual flow. The second one is maintaining a proper hygiene and cleanliness during the process of menstruation. 3 is eating a balanced diet to provide the body essential nutrients. And finally, maintaining an active lifestyle. Like previously, it was said that one should restrain oneself from playing or other physical activities. That is completely a myth. One should maintain an active lifestyle while avoiding stress and tension.
So, Priya, what are the common things that are used in menstrual cycles? What do the girls use actually?
And before coming to this slide, sorry for interrupting you. Yeah, I'd like to discuss this slide first. Yeah. Ma'am, the next slide, the slide next to it. The next one, ma'am, the next one. The slide next to this. How do we manage how to manage the menstrual flow? So there are various devices. During menstruation, the menstrual fluid needs to be absorbed and disposed of because there's about 20 to 80 ml of fluid of menstrual blood that is shedded during menstruation, and that needs to be absorbed and disposed of. And for that, we have various devices from sanitary pads, both disposable, as well as homemade cloth to tampons and menstrual cups, right? So disposable sanitary pads, a lot of advertisements. And as the time has passed, there are various generations of sanitary pads from thin to ultra thin sanitary pads have come up with wings and the pads that stick to the underpants and all those things. And no need to explain all those things because they're very well known to common populace. There are also homemade cloths which are reusable, and these are all the commercially available pads. They are all disposable pads. On the other hand, there are homemade cloth pads which are available. They can be washed and dried, and this drying should be always done under the sun because sun is all the sunlight kills germs. Previously, it was a taboo and drying was not done in public places just to hide it from the public eye. And so it was not a very hygienic drying. The drying was So, and it was reused. It still is practiced in various places. So there's the reusable homemade pads are there. Apart from that, tampons are there. Tampons are made of, these are cylindrical in shape with a string attached to one end. So this is made up of an absorbable material, and this needs to be inserted inside the vagina with the help of fingers with a string attached to the outer end, and this helps in removing the tampon. So both the pads as well as the tampons, these need to be changed every 6 to 8 hours, right? Because if the tampons are left inside the vagina for a pretty long time, they rarely, but these can lead to infections, and sometimes a very serious infection, which all of us know, which is a toxic shock syndrome, TSS. So they should be removed very carefully and very proactively after 6 hours. Apart from that, there is another device which is known as a menstrual cup. It is made up of rubber, sometimes of silicone. It is shaped like a cup or a cone, and it is pliable. It can be folded and inserted inside the vagina. It holds and it absorbs, it takes over all the blood or whatever secretion is there. And at the end of the day, it can removed, and all the whatever secretion is washed over, and it can be reinserted. And this cup, at the end of the cycle, it can be removed, it can be cleaned, and it can be used for the next cycle. These are the 4 devices, commonly used devices, which are practiced for the managing the menstrual flow.
So how do we dispose? Do we put the sanitary pad into the flush and flush it out? How do we do?
Ma'am, I'd like to discuss a slide before that. I mean, 2 slides before. Can we go to that slide, please?
This one?
Dr. Priyali, we need
Before
to.
that,
Yeah, I was hurrying, but madam wants to talk. So
Yeah, it is very interesting and very useful. But our
Yeah,
two youth are waiting, Rahul and this thing from you. They are.
so we'll discuss. Okay, okay, madam.
A slide
Fine, Priya,
just
madam.
before that. A slide just before that, I'd like to discuss. Ma'am,
Yes,
this is
ma'am.
about the hygiene that we need to maintain during the menstruation. Previously, there was a myth that we should not take bath during, because we could catch cold or something like that. This is completely a myth. We should bathe regularly and keep ourselves clean, and use clean and dried clothes, sun-dried clothes. We should change pads and tampons regularly, as I discussed before. Pads and tampons should be changed at 6-hourly intervals. We should clean our genitals and private parts clean and dry. And as somebody mentioned previously in our presentation, the vagina should not be douched or should not be cleaned, or vaginal washers as they show in TV commercials, they should not be used, because there is a natural cleaning process in the vagina. There is natural mucus secretion which keeps the vaginal pH in place, as the pH of the vagina ranges from 3.5 to 4.5. And that keeps the vagina clean and naturally clean. So it should not be clean and there's no need to clean it, extra clean it, right? So now coming to disposal of the sanitary napkins. After use, the sanitary pad or the tampon should never be flushed down the toilet, because it may clog the drainage system and it may lead to flooding of the toilet. Even disposing the non-biodegradable sanitary pads in pit latrines leads to quick filling and thus shorten the service of the pit latrines. So disposed products may get contaminated with germs and they emit a foul smell. So what needs to be done?
What happens if they are not properly disposed?
I mean, ma'am, they'll attract flies. They'll, if they're left in the open, they are a sore site, of course, and they may lead to transmission of infection like hepatitis B and so many other infections. They'll attract flies and insects, and of course, that is not desirable at all. So what we need to do is, yes, ma'am.
You keep on speaking if you want to, and then we'll have the last.
They are time constrained. That's what I am realizing.
That is what.
So after the tampons, they need to be removed after picking on the string that is attached to the outer end, or after removal of the sanitary napkin. They need to be wrapped in a paper, and they should put in a dustbin which is provided with a lid. And then the lid should be covered, and then wash your hands. That is how they should be disposed.
Thank you so much, ma'am. Sorry for the time constraints. So there are some tips at Menarche also, which madam would be giving. So, ma'am, will you please finish this last slide?
Sure, ma'am. We should be eating healthy, eat fruits, vegetables, and iron-rich food. Iron tablets and regular deworming should be done. We should decrease the intake of coffees, caffeine-rich, and sweets, and sodium intake. Daily exercise at least 1 hour per day. We should maintain a normal BMI. There should be some time for relaxation and some sort of education on sex education and also education on menstrual hygiene should be done.
Thank you so much, ma'am. So, breaking the taboo around menstruation in India requires open conversations, so which we will be having from the youth voice. We need to educate, we need a cultural change, and it is, as I mean to say, that it is not just a woman's issue as we make it, it's a basic human right, it's a basic health right. So, all of us need to give it a momentum. And thank you so much, panelists, and thank you all for patient listening. Thank you so much. Sridevi, you can take over now.
Yes, Sridevi.
Thank you, ma'am. Thank you very much, and thank you.
So Sridevi is a adolescent specialist from Vijayawada, Andhra Pradesh, and she's an executive board member of the AHA of AP, Andhra Pradesh. And she's very, very active secretary of the IAP Andhra Pradesh branch too. Sridevi, over to you.
Thank you, ma'am. Thank you for the introduction. And good evening, all the senior faculty and Central AHA members. Today, I am with my youth partners, Miss Naumika Khanna and Mr. Rahul. And I would like to say a few words about these young dynamic persons. Naumika Khanna, she is from Mohali, Punjab. She is now currently doing her master's in psychology. She is involved in so many organizations. There are so many. She is a Youth Wellness Day contributor, UNICEF Youth Ambassador, and she is a guest speaker in epilepsy programs, and so many are there for her credit. So,
very talented.
as a short, because time is very short, I would like to directly go to questionnaire. With Naumika. Please unmute yourself, Naumika. I would like to hear from your story, like, how do you feel, what do you think, and how much, where what adolescents think about all these menstrual hygiene. Over to you, Naumika.
So am I audible?
Yeah, you are audible.
Okay. So good evening to all the dignitaries. I'm Naumika Khanna, and as Sri Devi ma'am told you, I'm an NCD advocate and a youth voice. So I would like to tell that my first menstrual cycle was at 15. It is quite late according to the society's standards, and yet it was because I had hypothyroidism and type 1 diabetes also, which delayed it. Right now, I'm also suffering from PCOD, which weighs down your body both physically as well as psychologically. Yet my story is not rare. It is also not unique. Rather, it's shared by millions of girls across India who are silenced by stigma and shut down by systems across. I would also like to say that as we studied and this discussion went through, adolescent gynecology is not a luxury, rather it's a necessity. And I would also like to tell you that somebody also mentioned an example of school. So in our generation itself, even though the schools and colleges are competent enough to teach us trigonometry, maths, Hindi, whatever you say so, but they lack the basic structure to teach us issues that are related to adolescent gynecology. Also, as Dr. Prakriti iterated that sexual intercourse is very important, and the importance of healthy sexual intercourse is what I want to term, and the importance of consent. Moreover, as adolescents, we are just told that don't do it, or maybe sexual intercourse is some form of sin. And after marriage, there's a Nike tagline that I would like to say. Most of the girls are pressurized by their families to just do it. We are not given a manual, neither we are given a choice. So when we are touched, or whenever a child is touched without consent, abused, and whenever a teenage gets pregnant, as Dr. Pragati says so, after a rape or whatever, we usually blame the girl, and even small boys are the victims who are blamed. But they are never, we do not blame, never, kind of blame the perpetrators. We usually, hear from the society that what was she wearing? Was she alone? Why didn't she say so? And like if she had a choice. Because adolescents today, as you discussed, today need a proper counseling that is with proper ethical considerations that are related to contraceptives, like a lot of doctors mentioned the various kinds of contraceptives, STD awareness, mental health support during teenage pregnancy, and safe spaces which say that I don't understand my body, please help me. Also, I would like to just iterate that sex education is not shameful at all. Rather, it's life saving. Moreover, I would also like to mention that the current DSM that we are following, DSM 5, is also introduced a very proper disorder known as pornography disorder. That is very prevalent among both adolescents, children, and adults themselves. That is, they could get addicted to the pornographical material which is rampant on the internet. And I wouldn't like to talk more about it, but as everybody should be aware about it. Rather, we also got to know that there are some cultural taboos, judgments, and clinics which still are doing sex identification and abortions, homes that do not feel understanding at all, and schools which do not say enough. And while adolescents are actually suffering all of these, the shelves in must be all of our homes are quite filled with ultra processed foods, which I would like to say, such as those wonderful packets of Maggie or real juices, which we consider to be nutritious, but in fact are not. As adolescents or even as children, no one in India actually gets the knowledge about the ultra processed foods and how they can hamper with our hormones, progesterone, estrogen, and also trigger insulin resistance, like the endocrinologist said so. And also feed various NCDs like type 1 diabetes, PCOS, PCOD, like fires feed smoke. We eat them in silence, usually, and also suffer later in silence. It's rightly said that let food be thy medicines, and medicine be thy food.
Thank
And
you, Namika. I think you
last,
have to introduce your friend also, Rahul.
last but not
Rahul
least, last thing.
Wants to
This
say
is the
something.
last
Yeah.
thing.
Please go ahead. Yeah.
As Pam mentioned that movies like Padman, Netflix shows like Sex Education, Never Have I Ever, Like a Girl, Touch the Pickle by Whisperer, lot of, empowering things. Last is like we need education, not fear, support, not stigma, equity, not excuses. That's it. And have a
Great.
good night.
Thank you.
Great, yeah.
बहुत बढ़िया,
Very nice presentation. And now we understand the adolescent mind, though we know, but after hearing, no, we become more, more sensitive to all these issues. Thank you, Naumika. Now I would like to introduce Mr. Rahul Bachpan. Rahul Singla. He started an organization, Bachpan India, and through this organization, he sensitized many stakeholders and conducted many workshops regarding about the sexual abuse. And he is very he worked a lot and he received so many awards for his work. And he also trained so many NCC and NSS units. He conducts many education programs or sensitizing programs in colleges and schools. And he received many awards and many achievements. And with this vast experience, I would like to ask him few questions that because his experience is very much useful for us too. And hello Rahul, welcome you to this session.
Hi, good evening, doctor. How are you? Thanks
Yeah.
to you and thanks for Nomika for connecting to this space.
Thank you, Rahul, for coming to our AHA Adolescent Health Academy platform.
It's a pleasure. It's a pleasure, doctor. Thank you so much. Please.
Yeah, that we would like to ask, like, how rampant, how is sexual abuse, and what are the factors leading to this sexual abuse, and which gender is actually being
Yeah.
suffered most?
Right. So I think those are two questions. So I'll answer them one by one.
Yeah,
So
yeah.
how rampant it is, I think one of the most complex thing about child sexual abuse is, I mean, all of you are doctors, so I'm very sure that you're aware that it's a very deep, very grievous and unfortunate problem. But the major problem about this issue is that it is so common and yet it is very uncommon. What I mean by that statement is that it happens everywhere, unfortunately, but still a lot of people, even the most educated ones, and of course not the uneducated ones, they usually don't talk about it. Both have their own reasons. One has the reason of reputation and all other things. Other sector or the other domain, that is the rural people, have their own issues due to unawareness. Um, Almost one in every two child has unfortunately gone through child sexual abuse. Talking about gender specific, so this is the back start of 2007, where it basically said that out of children who have gone through sexual abuse, 53% of them were boys, not girls. So when I read about the stat, I was also shocked to the core because all my life I have been in this myth that this majorly happens usually with females. So that was kind of shocking to me in my own space as well. Another thing which adds to this problem is that less than 5% cases are reported of child sexual abuse, which is again a big problem. And this is directly related to the next fact, that is that in majority of the cases, the known person is someone who's accused of the abuser. Because it's someone known, that's why the reporting is so less. So all these combined factors make this issue very, very uncommon. It becomes very complex for the child to even understand that is the child being loved or is the child being sexually abused, because it's the known people who do it. And then also very small, small things. I mean, something we all have heard about, like good touch, bad touch. Like I personally, I'm usually against this terminology, and US doctors would kind of relate, because what we usually tell children when we talk about bad touch is that if someone touches you on the private parts, it is a bad touch. Just an example. But we also know biologically, if someone touches a child on private parts, the child can feel pleasure. That's how the body is. That there are erogenous zones and other things on the body. But then it's a confusion for the child, because all their life they have been taught that, oh, this is bad touch. But if they're feeling good about it, if they're feeling pleasure about it, that is not being validated. And then the child feels that, oh, maybe I am sick, maybe it's a disease, because I should have felt bad, but I didn't feel bad. One of the reasons why a lot of sexual abuse or rape survivors always thought that um, because internally they felt good about it, so it was maybe their mistake, it was the guilt, it was they wanted it, but it was never like that. So all these kind of mixed things, the infra of the judicial system, all these small, small sensitive topics definitely makes it a very big problem.
Yeah. Um, what are the protective factors? I mean, to protect children from sexual abuse, and how to, I mean, train our
Yeah.
children to recognize and
Definitely. I
yeah.
think the good news is that though it's a very complex problem, but the solution is very simple. Like most of the problems, the solution here is not very complex. The very simple solution is what Nomika was also mentioning, is sex education. So just basic communication from the very beginning, just educating children about the body parts, personal boundaries, consent, talking openly about relationships, trying to give them logical answers. So what is happening with this generation is, because there is that so much bombardment of information from the digital world, digital media and all those things, children are usually confused to filter the information, that what is right and what is wrong. And what even creates a bigger problem for this generation is that, because mostly parents are working, and I mean, not to blame them, because there is so much inflation and other things going on. When there is so much bombardment of information, there is no one to tell them what is right and what is wrong. And ultimately, that's the misguidance that usually happens, and then they get distracted. So, just basic sitting with children, maybe 15-20 minutes every day, and discussing the entire day, and just addressing their problems, even if you don't know, still addressing ki it's fine, I don't know about it right now. I'll talk to someone, I'll talk to a specialist, 2-3 दिन मुझे दीजिए, and I'll come back and try to give you an answer. That is enough to reduce 50% of cases of child sexual abuse, because then you are still in the safe circle of the child. But once you kind of negate those questions, you tell them, oh, this is bad, this is really bad, तू बिगड़ गया है, तू बिगड़ गई है. That's the point where basically you come out of the safe circle of the child. And then that leaves a lot of space for groomers or pedophiles to basically sexually abuse the child. So yeah, but just very simple things of talking to the child, I think, is the solution.
How can we prevent these behaviors, actually, these negative behaviors among children, so that they will not get the feeling like, how to raise them? Any suggestions on that?
So I think this question can be relevant in two ways. It can be relevant to children who are accused, I mean, who commit crimes, juveniles.
Yeah.
And second part can be addressed to children who are victims of this crime. This also brings me to a very complex and amazing stat that 33% of children who have been through sexual abuse, they tend to become abusers when they grow up. So, and this is like a double-edged sword. So my hypothetical situation is, what if we can talk to these 33% children who are potentially going to become abusers and try to understand why they will be doing this, and maybe try to help them or heal them. So we are basically, हम बोलते हैं ना, एक तीर से दो निशाने होने वाले हैं, because we are also going to help the victim child, and also we are going to help them not becoming abusers, and also not kind of reducing the upcoming 33% children who can be potential victims. So regarding this, why I mentioned this stat is because 33% people, children who are getting abused, if they are becoming abusers in future, it means they are not being heard, they are not being listened, they are, the therapy or the therapeutic interventions are not being normal. So the simple point is, can parents or other stakeholders like teachers, doctors, police officials just not make them feel really worse, not kind of secondary victimize them, just try to, you know, just try to validate, tell them it's not their fault, it's not their mistake, it's not their guilt, it's fine, it happened, they are not weak, they are brave, they are strong. Just these 5-6 magical words can kind of help in a lot of ways. So when you do these things, ultimately you are going to reduce a lot of children who can be abusers. With respect to second part, doctor, I mean, what kind of preventive measures can victim use? I mean, the children use who can be victimized. I think the only thing children can do is just, try to identify certain signs that are potentially of abuse. But again, what I feel on this is that I don't think children can do um, ever enough, because child sexual abuse prevention is never a child's responsibility. It is always an adult's responsibility.
Yes.
It's always going to be adults who have to be really careful around the child. I mean, the child is always going to make mistakes. So I think the better answer to this may be, what can parents or what can other adult stakeholders do about it? Maybe.
Yeah, that's what my question was. Actually,
Okay.
parent rearing practices like,
Yeah.
gender equality and listening to them, and also not abusing them, or
Yeah.
not having so many.
I can also just take
Yeah,
30 more seconds to maybe put more light on that as well. I
yeah,
mean, what's also very important is the better parenting methods. Like,
yeah,
for example, a lot of cases where child sexual abuse happens is usually when there is a lot of family violence going on, when there is a domestic abuse going on within the family. Second, when children are very small, I mean, all of you are quite aware about the mirror neurons. So usually what children see, they are going to replicate that behavior in their, upcoming, when they are going to be teenagers or adults. So I think what parents do, the way they resolve conflicts, the way, they talk to each other about arguments, that really is going to take what child is going to take in the future. So that is very important. Second thing is consent. So there was this very famous line that we also use, that a lot of parents unfortunately thought child as their own property, uh, which is, I mean, it's a very wrong sentence to say, but that's actually true. Why I mean to say that is that they always had this thought कि जैसे हम बोलेंगे तुमको वैसे ही करना है क्या है. That is the way how you should be reacting. So ultimately, they wanted to care for the child, but that somehow turned into restriction of their freedom. And that is where they lost the bond with the child. Other things can be comparisons. I mean, parents can feel that comparisons can work as negative motivations, but not always. Those comparisons can actually distance the child away from the parents. So that is very important, that how you kind of talk to the child. And इवन अगर आपको कुछ समझाना भी है, आप उस तरीके से समझाइए कि बच्चे को बुलीड या कंपेयर्ड ना फील हो. सो ऑल दो सिंपल थिंग्स आई थिंक आर जस्ट वेरी इंपॉर्टेंट.
राहुल, आपके साथ अलग सेशन चाहिए पूरा 1 घंटे का.
That's very true, ma'am, because this is the another side of the coin now we are listening to. And very nicely done, by nicely explained, Rahul. Thank you very much
Thank
for
you.
your thoughts.
Thank you.
Yeah, I do
So-
feel so because his statistics are amazing, really. Because he gives on-field record about it. Even
Thank
though
you,
I
ma'am.
gave what I felt, like the cognition part of it, Rahul gives the on-field record of it. That's amazing.
That's great, both of you. Thank you, Dr. Rahul. I'm so used to saying doctors, but Rahul and Naumika, you had made us in this webinar, you are the shining stars. And of course, our panelists and our speakers were just excellent today. Yeah, and it's been more than nearly 2 hours now. Still, we are all, hooked.
Yeah.
So I think we should have separate sessions with you, and I request you to please join our Wave 18 programs where we have more of youth voices heard. So this is a mix when we have these webinars, monthly webinars. We have academic webinars where our pediatricians also have their own space, and we invite our youth. But in the Wave 18, it is 80% आपका ही है, पूरा youth voice है. So please be with us, and we'll definitely plan some activity, Rahul. I
Sure.
think you're working so much. Let us see how we can collaborate with Adolescent Health Academy and IAP on this very important issue. From my side,
Definitely.
and HA, we really thank you. And there are a lot of questions. I think Sangeeta Yadav madam is still there, or Shamik, you can just moderate to Dr. Sridevi. Are you okay? Finished with it, or you want still something else is there?
Ma'am, we finished our we
Thank you
concluded
much.
our session.
You have been so gentle and so handling this youth. Thank you. So over to Shamik to just see if there's some questions to be answered from the chat box before we
Thank
close.
you so much, ma'am. And it's been an absolute learning pleasure for all of us. We've just been listening in such a focused manner, and we've also got the other side of the coin. And I just commented at some point that this is why we want the youth voice. And I just hope we can work around giving them more space in these webinars, because if we realize towards the end, the questions that they are
You can
putting
ask some
to us,
questions. Yeah. We can
so the
insert the youth
questions,
voice in between next time.
yeah, so that the lot of the theoretical matter that is being discussed during our panel discussion or during our lectures, a lot of it is actually going to come across as questions from the youth. So then it leaves a better impression, and we have more take-home messages. I must say thank Dr. Pragati Khalatkar for having opened up a Pandora's box on teenage pregnancy, wherein if you look at the NFHS survey, we are nearly dealing with 7% of our adolescent population becoming pregnant, which is a startling statistics. There may be some regional skews over there, but it is a burning problem. And if we are going to be adolescent pediatricians, we have to be well equipped to handle these pregnancies. The second part of the panel discussions, I think, so beautifully touched upon common day-to-day problems in adolescent practice, and immense thanks to Dr. Piyali Bhattacharya, who always makes things very simple, and she manages to give us so many take-home messages. She's very blunt at times, and she makes it a point that we don't go back without any take-home messages. I was so impressed with our endocrinologist, who had such a practical approach to PCOS, and probably we should have a session with her where she can also enlighten us about what we really find difficult to diagnose, that is the thin PCOS. So most of us have been very enlightened. Thank you so much for everybody joining and putting up. And Naumika and Rahul, I've written in the chat also. I just wish we had more time with you. Rahul,
We have,
thanks a
we
ton.
have it.
Your
We plan it, yeah.
So your thoughts have been really refined by the work that you actually do at the grassroots. It's so clear cut. You know what you're dealing with. Your thoughts have been molded accordingly, and I'm sure we will benefit from more
Shamik, there's some
interactions with
questions.
you.
There's some
Ma'am,
questions.
there are
Can you
no
see
more
them?
questions. I've checked the chat. There aren't any questions.
Questions, okay.
Most of it is about
And actually, I
how
want to
good
ask the youth.
today's webinar.
Yeah, just a minute, Shamik. This is one, sleeping together. So when these children should be sleeping in another rooms away from parents, what is the opinion of the youth here? Both Naumika and Rahul. Dr. Usha Banga has also expressed something. So I just want their view. So when should you think that you need a separate room to sleep, or should we, in the US it is they separate the children quite early, but we keep on hugging them, and we still, we love to be in one room all the time. And what do you think the space, or at least the sleeping, this is one thing, can you tell this can be raised by parents also?
Definitely. So, should I take that first?
Yeah, please.
Okay. That reminds me of a very wonderful example that I usually give of that. Should parents be kissing their children on the lips? The answer is no. Because then the child won't be able to differentiate between love and abuse a lot of times. It's a similar situation that when what is the appropriate age? Ideally, of course, we should be following what foreign countries follow, but practically due to population and not so economic stated, that wouldn't be possible in India. But ideally speaking, I mean, as soon as the kind of adolescent changes do start, they should be sleeping away. Because boys are usually, we would see teenage boys or even younger than that, maybe in the age of 5, 6 also, boys would usually wake up with hands in their pants. But parents wouldn't take that emotion or that scenario very nicely. They would usually kind of बच्चे को डांट देंगे, verbally abuse करेंगे कि तू बिगड़ गया, but that is just a very normal point to explore their bodies. But when the girl and boy are just sleeping together, even if they're siblings, those kind of activities can make each other uncomfortable, especially in a conditioning in India when they're not actually aware about what is happening around. It's just happening very automatically, very consciously, but they're not aware why it is happening out. So that can really make each other very uncomfortable and kind of disturb the family dynamics. So in that perspective, they should be sleeping in different rooms, possibly.
As they're getting the changes happening, right?
Exactly. Yeah.
The physical, right?
No.
Usha, madam.
Above the age of 9 years, sleeping
9
in
years.
the same room is considered social overcrowding. This is the definition given by PSM, Preventive and Social Medicines.
9 years.
Yes. We should also talk about these issues when we are seeing our adolescent or any patient. I have seen just by casual talk, they say she sleeps with her father. Then father says she has fever, this and that. Then I advise them not to sleep with father.
Yeah, good. Thank you. That was very clear. So, I mean, actually, this topic, Pragati ji is still there. When we discussed about the topic, we both just thought that let us concentrate on the theme of the World Health Day. That is bringing down it is early nurturing and, the beginnings and all that. So, वहाँ पे global call for reduction of teenage pregnancy था. So, we thought that IAP and AHA should join this global call and talk more about how to reduce teenage pregnancy. And we have a big responsibility as Adolescent Health Academy. So let us have some action initiated. I hope one of the state branches or any of us can take up some action related to reducing teenage pregnancy. And the youth can also be, I think I should ask the Nomika and all, if one of you can take lead, some of you can take lead, youth, we can join you, or it can be vice versa. So let us think about it and ponder. So thank you.
Can I add one point, Dr. Hima?
Yeah, Dr. Ritu, yes.
Yeah, so I just wanted to add there's another side of the coin that even parents need privacy. So it's good to separate them as they are growing. Otherwise, it will impact the relationship of the parents and also the kids, they're like, a very impressionable age. So they may get negatively impacted if by accident also they see something, they see their parents being intimate.
Then
So
it should be early also, not 9 years. That
yeah,
maybe
yeah. It could be earlier also. As soon as we feel that, oh, kids are okay, mature enough, they can sleep separately, they'll take care, and you can always have a like keep an eye on them, or maybe so some arrangement like that. Yeah, that is what I wanted to add.
I am telling about not parents, but otherwise also.
Yeah,
Like
yeah, ma'am. So I was just
relatives when
adding
they
to what you
come,
said.
sometimes relatives meet the families. Then people ask them, "Mama का लड़का है, चलो सो जाओ इधर एक
Yeah,
कमरे में."
yeah,
That should not be allowed.
Yeah.
Yes. So we need to look at all the aspects.
Yes.
Thank you. I think we are still, I mean, not closing down, and very interesting discussions happening. Dr. Sangeeta Yadav, madam, thank you for being with us, our past chairperson of Adolescent Health Academy. I'd like to especially thank her, Dr. Sridevi, and Dr. Piali, who had made this very nice, interesting discussions, moderated discussions. Thank you, Dr. Piali and Dr. Sridevi, and our youth. I think we all have to give a big round of applause to our Nomika and Dr. and Miss Rahul. So we look forward for your further participation. We have already added you in the HA Youth Forum. So please give us ideas. We have just started this youth forum, so we are in the nascent stage, but we would like to have your participation. You are welcome always. Yeah. Thank you. Anything, and we can close if we are
कल
all.
के लिए सबको इनवाइट कर लीजिए कल के
Yeah, Dr. Prakash. Thank you. I'm correct. As a secretary, thank you. You have reminded us. So tomorrow, 18th of April, we have another wave. We want to create this wave actually. Well, adolescents, empowered, vibrant, Empower Yuva program initiative of the Silver Jubilee year of AHA. So this is the fourth time, and this is actually being partnered by the UNICEF. So the 18th of every day being called as Youth Wellness Day has gone well with the UNICEF, and maybe the ministry also will take it up. So even Rajasthan IAP is celebrating now 18th. I saw some post Rajasthan is also celebrating tomorrow. So let us join at 4 o'clock. So this is at 4 because we don't want to clash with the classes of the young people. So when we earlier put at 3 o'clock, it was, they were missing some classes. So a request had come, and we thought let us do at 4 to 5:30. And Naumika, I think she'll connect us with a lot of youth groups tomorrow. And the theme is on preconception care, another bold topic. And this is for the young above 18 years, 18 to 24. So we have the main team, the Wave 18 team has created 2 youth-led panel discussions tomorrow. So it will be led by the youth. The moderators will be the young people. And we have the pediatricians as the panelists. And we are also releasing a skit and on preconception care by Rashmi Gupta ji. And one song nicely done by Smita Mishra from Delhi. And quiz every week, every month we have this quiz, the results and the winners, all that will be tomorrow will be announced. So please do join and make it a big success, because this is a very unique program where the youth are on the forefront. Thank you. Please don't forget to join tomorrow at 4 o'clock. Thank you.
I'd just like to ask last question to Dr. Pragati. She
Dr.
very
Pragati?
Yeah. So I would like to ask her, since she described postpartum depression, and I'm also a master's student in psychology. So are there any laws for, teenagers or even adult mothers if they fall in postpartum depression? Because in India it is very rampant actually. They have to be inside their homes, they have to take care of the baby, they can't spend their time otherwise, and you must know better. So, are there any laws or insurance that is covering for postpartum depression inside India? I don't know elsewhere.
To my knowledge, no. I think we have to raise a voice for that also. Anybody here can also answer. I think Pragati is not here. Dr. Piali?
Ma'am.
Chamik.
Yeah.
Postpartum
Naumika,
depression covered by insurance
yes.
or not?
No, definitely not covered.
No.
But
No.
what is actually missing, I think, so over here is the antenatal parent craft classes, because most of the reasons for the postnatal depression that mothers go into is because they literally don't know how to handle the baby. They are not aware of when the milk is going to be let down. They are not aware of what the normal bowel habit of the child is. They are not aware of how to approach a crying child. So, very common day to day issues. And they are also under the impression that because the child has been born, it's a 24/7 into 365-day awake duty for them. Nobody counsels them that nature has given them enough provisions to rest their minds and their bodies for adequate periods. So, yes, it is a problem which can only and only be tackled if there are adequate antenatal parent craft classes for these mothers.
And I think that we can also contact the respective stakeholders regarding these things.
Yeah, I mean, it is a norm in most of the antenatal classes or clinics in the developed world. And over here, we do, I mean, some of us who've been trained abroad, we have been trying to implement it in our practice, but it's like a drop in the ocean. But if it is incorporated, at least 1 or 2 sessions are incorporated during those 9 months of antenatal checkup as what to expect immediately after the birth of your child, it would go a long way in clearing the anxieties that these mothers have after the child is born. I mean, as doctors, as caregivers, any third person, we will never understand the enormity of the responsibility that the mother has about a live born newborn. वो सोचता है कि this is, I mean, they are totally dependent on me for their survival. If I do anything wrong, the survival of the child may be endangered, and that puts a huge pressure on the mother. So we need to really, really put in a lot of effort and make this parent craft classes an integral part of antenatal care for all expectant mothers.
Hemabindu ma'am, may I say something?
Yes, ma'am. Please go ahead.
I just checked with my cousin who is in the insurance company just now while this was going on. And he says that, yes, the postpartum depression is covered under insurance, but it depends on the type of policy which the person has taken. But it is covered under depression in India also.
Thank you. Thank you, ma'am. I wasn't aware of that. Because a lot of
That's
yeah.
beautiful, ma'am, that you kind of share the knowledge. You can definitely put it on the group. That's beautiful that if it's covered, maybe our cousins or somebody who's giving birth, they could take those kind of health insurances. They
Which
should be
insurance,
aware.
Dr. Shalini? Just you can mention that. Thank you. Yeah. Thank you.
Yes,
I
ma'am.
think we should
Time to say good night.
Screen time is also not nice. Yeah.
Excellent program. Ma'am, and over 2.25 hours. Excellent program.
Yes.
It was, all the topics were so intensively covered.
Beautiful.
And
Very
it was
nice.
so difficult to stop people. So I think so nice. Dr. Piali, thank you so much. You had made it so good, and all the panelists have really gone to the depth of the
My
subject.
panelists were extremely good. We must say a
All
real
the-
applause to all the panelists because we tried to be very simple, but the knowledge has to go, the awareness has to go. And I must appreciate both Naumika and Rahul. Rahul was extremely confident. He's on the field, it seems. He was talking about what and how, absolutely as if he was in touch with those people, as he says. He's been on the field working there. And Naumika also is doing a master's in psychology. So she probably has guessed what our psychology would be, and she has spoken likewise. So kudos to you, Naumika.
Yeah. We're
Very
looking forward
nice.
to both of them.
Yeah.
And Dr. Piali, thank you for coming and talking to these young people and all of you. Thank you so much. Thank you.
Good night. Good night to all of you. Thank you so
Good night.
much. Bye.
Please do join tomorrow, 4 o'clock.
Good night. Thank you.